Need to know. Forward.
Hey, Ral, I've started the recording.
Great. Right. Are we on? Yep. Hi, everyone. Welcome to our Gaps and Opportunities in Clinical Detection of Late. Really excited to have this meeting. We've been talking about it for a number of months moving forward, and it's great to finally be here, and certainly welcome to all of the people who are online watching this event, and hopefully will be both entertaining, provocative, and really lead to some good discussion. I do want to just thank NIA for supporting this event, and the entire team, Grayson, Erica, Sasha, and certainly Nina for being a champion of pulling this together. And so it's really great to be there. and Linda as well for, I'm sorry. Thank you, Linda. And also to my co-organizers, Julie Schneider and Pete Nelson as well. And all of you for the committees for all the work that you did, and certainly for the people who pulled talks together, sometimes with a little bit of encouragement from myself and others. You know who you are. So I'm going to start off with kind of giving an overview of why we wanted to create this workshop, what the goals of the workshop are, maybe provide a little bit of background. There's then going to be two other background talks from Julie and Pete, and then we'll kind of go into the meat of the day. Here are my disclosures. All right, so why have this workshop now? You know, why would we want to kind of go ahead and start to think about clinical detection of late? I think, you know, obviously over the last, decade or so, there's really been a growing awareness of TDP-43 as an important modulator of late life cognitive decline. And then I think that was really accelerated or catalyzed by the codification of late as a construct, late neuropathic change in 2019, led by Pete and many others, to really define a condition. And with a name and awareness, there's increased recognition from clinicians of patients with syndromes that seem, quote unquote, late-like. You know, as they say, diagnosticians got to diagnose. Actually, I don't think anyone's ever said that before. But if they did, they would say that. And once you start to know about an entity, you start to think about it in your patients. And I think, a lot of us have started to make this, or at least entertain this diagnosis. And then I actually think this importance has really been amplified by the emergence of disease-modifying medicine targeting AD biology, because I think that really is going to propel us. It's going to force us to be in a more precision medicine type of era. The reality is late and Alzheimer's disease have a similar phenotype, have a lot of clinical overlap. And so there's going to be a number of patients that we see that we're screening for lecanemab, donanemab, who are going to be amyloid negative. And I think a lot of those patients will likely have late as a driver of their symptoms. And then I think the other area, just as important, is that late frequently co-occurs with Alzheimer's disease. And in general, we as a field need to think about co-pathologies with Alzheimer's disease and how that interacts with the therapies that we use, and really have a better way of defining individuals within those spectrums to start to learn who's more likely to be responsive to one of these drugs, who's less likely to be responsive. So even though there was sort of this codification of late in 2019, actually the notion that TDP is an important driver of age-associated cognitive decline and is associated with Alzheimer's disease has actually been around for many years, and there's been a lot of great work in this. So, for example, Dennis Dixon in 1994 described hippocampal sclerosis as being common in individuals who didn't have Alzheimer's disease over the age of 80. So about a quarter of those individuals in his initial report had hippocampal sclerosis. Actually, there's a quote in there where they say, in some patients, memory disturbance was disproportionate to deficits in other cognitive areas. I think that's consistent with what we start to think about for late. Then, really importantly, in 2006, TDP-43 was recognized as the primary inclusion in FTLD ALS, and since then we've then learned that TDP-43 actually is very common in age-associated hippocampal sclerosis. So I think Pete's going to show some data later, but it's the vast majority of these cases. And so this hippocampal sclerosis, to a large extent, reflect late. This is just from that original paper in 1994 showing just the profound segmental loss of neurons in CA1 relative to preservation in CA2 and 3. It's a pretty remarkable looking image. With time, more recently, work done by Keith Josephs and a number of other people, we've learned that TDP-43 often co-occurs with Alzheimer's disease, and it is associated independently with hippocampal structure and memory decline, and it's further independent from hippocampal sclerosis. So TDP-43, even in the absence of true hippocampal sclerosis, still modifies cognition and structure. And on the other hand, it's also common in the absence of Alzheimer's disease. And so individuals over the age of 80, about a third of them or more have TDP-43, and it tends to be associated with episodic and perhaps some degree of semantic impairment. The reality is, when people have looked at these individuals, the TDP-43 seems to be primarily in limbic areas, and there does seem to be a staging to how it evolves over time, and a number of groups have worked on staging systems for it. But then in 2019, and then recently updated, I think just published a couple months ago, this year was the late NC criteria, pathologic criteria. And I think it's useful to kind of look at these different staging systems. So, the late NC criteria are relatively simplified, and I think that's really helpful from a practical standpoint. But when we look at staging schemes that others have developed, I think it gives clues on what might be additional symptoms one would see outside of amnesia. So, for example, there's a fair bit of anterior temporal cortex TDP-43, orbital frontal cortex, insular involvement of TDP-43. And so when we think about later stage TDP-43, we might encompass a bit more of a spectrum of cognitive and behavioral changes. With the sort of series of pathology that has emerged over time, there's been a lot of work doing clinicopathologic correlation, and I think a kind of clinical characteristic has emerged of this this group of patients. They tend to have a prominent amnestic syndrome. I think there's varying degrees of semantic impairment. Some work has suggested some working memory, executive dysfunction in these patients. They're older. I think that's an important clinical feature that we need to think about. The reality is it's a mimic of Alzheimer's disease. It looks a lot like what we typically think of as typical Alzheimer's disease. Maybe a few differing features, although we'll hear more about this later, is maybe it's a bit more of an indolent course than Alzheimer's disease. I think personally, you don't tend to see a lot of parietal dysfunction. So the absence of visual spatial function may be a sign. And I think to some extent, in general, memory is disproportionately affected in many of these patients. So again, diagnosticians got to diagnose. I'm gonna pound that in until people start saying that. And with that definition, we started considering late in our own differential diagnosis, and I know many of you here have done that as well. And so this was a case that we saw in our center, in our Alzheimer's Disease Center, retired engineer in his early 80s with forgetfulness. One of the things that was striking to the family when they started to become a bit more worried about him was that his son had made the high school hockey team, and that was like a really big event in the family that he had made the team. And the patient was there and really excited about it. And the next day he had completely no recollection of the fact that his son had made the team. He was keeping more notes for reminders. He had mild inefficiencies with the finances. His instrumental activities of daily living, though, were otherwise okay. really no change in personality or language complaints. And actually his mini-mental was a 30 out of 30 at his initial visit with borderline memory performance. And this is what his MRI looked like, his initial one. And I think the most striking feature of his MRI, at least initially, was that there's sort of a flattening of the head of the hippocampus and sort of more space, a little less so on the left. And then this is what he looked like psychometrically over time, followed over the next 8 years. So this top line is his mini-mental status examination, which dropped a couple points on it, so not a lot of change there. We went to the MoCA after this, and I don't really trust our conversion scores to MMSE, so I dropped that out of the figure. This is his 10-item wordless memory task. So he was kind of borderline at the first visit, 5 out of 10, but pretty quickly went down to floor on memory tasks and sort of stayed that way throughout the entire course. And then one thing that I feel like we notice in a fair number of these patients is that category fluency, which is a measure of semantic function, tends to drop a little bit more quickly than lexical fluency, which is F words in this case, which is a kind of more frontally based lexical retrieval task. And I think category fluency often does go down in these patients. And naming went down in him too, to some extent over time as well. So he was diagnosed with first, I think, MCI due to AD and either dementia due to AD or stayed MCI due to AD by year 3. But he had an amyloid PET as part of research in year 5, and the amyloid PET scan was negative. And he had this MRI at that point, which was more profoundly atrophic. And a couple features that I think we see on a lot of these MRIs is there's a kind of widening of the collateral sulcus. And in particular, you see a fair bit of thinning, more so than we typically see in AD and perirhinal and entorhinal cortex. There's often really profound head of the hippocampus flattening. But the whole body of the hippocampus can be quite small. So this is the sort of body of the hippocampus here, which is really profoundly small, especially considering this person has a mini-mental of like 28 or 27 at the time of the scan. And so we actually clinically said, you know what, the criteria had come out. We think this case is a case of someone with late. And in fact, he had stage 3 late. He did have hippocampal sclerosis, not surprisingly, looking at his MRI. And he had actually really very, very little evidence, actually unusually low evidence of AD pathology. And so these are cases, and we see others that are not too dissimilar to him in our clinical practice more and more. If you start to know about something, you start to notice it more than we have in the past. So why even try to make a diagnosis of AD versus late? I think there's a number of reasons. First of all, I've said this before, our patients want diagnoses. They want to know what they have, what's driving their symptoms. I think it has prognostic value. So late tends to be a slower course. And so I think that's something that can be comforting to families, particularly comforting with regard to what other areas of cognition may or may not be affected over time. There may be therapeutic implications. We really don't know, actually, if like cholinesterase inhibitors and memantine make much of a difference in these patients, but it's something we should try to learn more about. But obviously, the big therapeutic implication nowadays, theoretically, would be anti-amyloid monoclonal antibodies. And again, I just to really emphasize this point, with disease-modifying medicines, a side effect of that will be the discovery of these amyloid-negative amnestic syndromes, many of whom will have late. So sometimes it gets trickier, though, to differentiate late from AD, right? So this is another one of our cases. This is a woman in her 70s with primarily memory complaints. She was forgetting appointments, conversations. She had less orientation to time. And then on the bottom is our psychometric battery. It's essentially the UDS testing with normative data or percentiles. And if you look through her testing, the areas that she had weakness on were largely memory, kind of borderline memory recall. This is logical memory, where she did a fair bit worse, actually, than wordless recall, and even had some visual recall deficits, but again, kind of borderline. Other domains were largely intact, although interestingly, she had a little bit of difficulty with clock draw. So she went on and had CSF testing and had low A beta, but normal total tau and phospho-tau. And so she was given a diagnosis of MCI due to Alzheimer's disease, which seemed pretty reasonable at the time, and then was eventually progressed to dementia and was called Alzheimer's disease. And this is her MRI around that same time. And again, I hope you can appreciate there's some widening of the collateral sulcus and thinning of the gray matter there in BA35 and entorhinal cortex. There's really, I think, pretty significant flattening of the head of the hippocampus and really small hippocampi in the body of the hippocampus as well. This is just another image. It's a FLAIR image where she had, you can again see there's real thinning of the medial temporal lobe. And she actually had a moderate amount of white matter hyperintensities. And vascular and how that relates to late is something that also, certainly could be a topic that might come up today. And then we do a kind of in-house quantitative measurement of hippocampal volumes. And this is where she sat. So green is the middle 75% range of amyloid negative controls. Blue is an MCI range, and then red is our Alzheimer's disease range of the middle 75%. And then we kind of use a 90% sensitivity line to say you're positive for hippocampal atrophy. And I know there's lots of debate about what kind of cutoffs to use. Bottom line is that she was well within the bottom quartile of individuals with Alzheimer's disease, even at this very early stage. And I think that's another theme here, is just quite simply individuals with late and maybe even the range in Alzheimer's disease. A lot of that lower part of that range might be driven by concomitant TDP-43. So not surprisingly, because I'm showing this case at a conference on late, she had late stage 3. She had intermediate Alzheimer's disease. I think what's striking is her her Brock stage using the 6-stage scale was 4, which she had lived another 15 years after we initially saw her. And with those really small hippocampi, the fact she was only at Brock stage 4 by the time she passed away makes it hard to believe that tangles was the driving pathology for her hippocampal atrophy. She also interestingly had amyloid angiopathy. Who knows what to make of that in this context, but she would have qualified for the lecanemab trial, right? So she had amyloid positive, MCI level impairment with memory loss. And so would that be the right treatment in her? At least at presentation, it seems like more likely that late was driving the etiology of her symptoms. Maybe it is the right treatment. Maybe reducing amyloid in these patients is a really good thing, that it helps with proteostasis and will have benefit for her. But I think these are things we need to learn. And the reality is we're going to see a lot of these patients like this. So this was data from Susan Landau for ADNI, where the late MCI patients who were amyloid positive, 25% of them were negative for BROC1/2 on tau PET. And so that's a pretty substantial portion of those individuals that might be like this patient. We found actually in another study that 1/3 of individuals that were amyloid positive and neurodegeneration positive, defined by hippocampal atrophy, were tau negative based on CSF. And when you look at these individuals, as well as individuals who are just neurodegeneration positive, generally where you see most of the atrophy is in these sort of anterior medial temporal regions. And so I think a significant proportion of these patients likely have late, obviously heterogeneous, but a significant proportion likely have late. Again, though, late is a co-pathology frequently with Alzheimer's disease, maybe up to 50% of cases. It seems that it's associated with the likelihood of cognitive impairment and rate of decline in these patients. And again, could influence disease-modifying medicines. And so I think we also have to think about, are there approaches to defining patients likely to have concomitant late when you also have full-blown Alzheimer's disease? And this is just work from Keith Josephs really nicely showing that in AD, those that are TDP-43 positive versus negative have a much faster rate of decline of the hippocampus, but the same is true for memory and other and overall cognitive status. So this is a challenging case. So this is a man in his 70s with primary forgetfulness, Mini-Mental's 26 out of 30. This is his testing. He really is profoundly amnestic. Other domains are largely intact, but not, not perfect, kind of borderline. He had positive tau and phospho-tau and A beta, so A positive, T positive. And this is his MRI. Again, mini-mental at 26, so not all that impaired, but he has the same widening and thinning of the perirhinal into entorhinal area, at least on the left, has a flattening of the head of the hippocampus, but also pretty profoundly small hippocampi in the body. He also is in the bottom quartile of AD patients, not quite as severe as the other patient, but certainly, gives you a little bit of pause. And he ended up having late stage 2 and full-blown AD. And so the question is, how much was TDP versus AD driving his symptoms, and how might that influence, outcomes in him? I think it's going to be really challenging to be able to pull out late and in patients with AD, but I think we need to start to think about ways to do it. One approach we've taken is a residual approach, where we basically define a normative amount of tau to neurodegeneration, either with PET or with MRI structure, and then look for deviance from that. And so what we find is that there is a group of people with FDG PET and MRI who have more severe temporal either hypometabolism or atrophy that we call like limbic vulnerable or susceptible. Relative to kind of the canonical group, they tend to have a faster rate of decline in both instances, so sort of what we expect with late plus AD. Excuse me. And in antemortem MRI imaging for people we had autopsy, we found that this limbic vulnerable group tends to have more TDP-43 in the medial temporal lobe. All right, so what are the goals of the workshop? To determine if we're at a point where we have enough confidence to categorize some patients as having late in practice and in research. Can we define a clinical syndrome associated with late, and are there biomarkers that can help support the link between the clinical syndrome and underlying late? We obviously realize, in the absence of a TDP-43 specific biomarker, which we all want, that we can't produce a biological definition of late. And we also realize that there, throughout all of neurology, certainly in neurodegenerative disease, there's not a one-to-one mapping of clinical presentation with pathology. So any clinical definition we provide here today, we have to accept the fact it's going to be probabilistic. And the reality is that's what we've been doing for a lot of years with neurodegenerative diseases, is most of our diagnoses are probabilistic. And so I think we just have to accept that and use that as a kind of guidepost for how we think about these conditions. The other thing is lots and lots of conditions affect the medial temporal lobe. So there's going to be overlap. It's a hotbed of pathology. I will say, though, for example, PART, there's at least some data that the amount that TDP-43 in the context of PART is an important modulator of atrophy and symptoms within that condition. Alpha-synuclein is another, although we've seen in postmortem studies, there's not a strong correlation between alpha-synuclein and structural changes, at least, although there certainly are metabolic deficits. There'll certainly be overlap with other conditions. I think the two major contexts we want to think about the detection of late, one is in the relative absence of Alzheimer's disease or other related dementias, and then the other is kind of within the AD pathophysiologic spectrum. We've talked a little bit about A positive, T minus. Maybe you would push that up to the top category. But then also when AD is sort of fully blown, that we have AD, but we also have concomitant late. Another goal will be to try to understand look at what we know in terms of the genetics and risks of late, how they might be integrated into diagnosis and used for enrichment in clinical trials. And I think we want to use what we know here and want to start to think about how this will influence clinical trials, both in studies that are directed towards late, but also studies that are directed towards AD. Can we define individuals with that are treated with anti-amyloid drugs that are more likely to have concomitant TDP-43? Even if it's probabilistic, should we start to look at those groups and study outcomes in them, or even go back to, if data is shared from Lilly and others, and look at those data sets for seeing, how are outcomes influenced by things that suggest late as concomitant pathology. The goals are also to find gaps, right? There are definitely gaps. We need a TDP-43 specific marker. We need to think about how we'll validate classification, what some of the challenges are to intervention studies in late. Hopefully we'll have some discussion about ethno-racial diversity in the studies of late. And I think there are certainly boundary issues with FTLD. A few words about nomenclature. I think there certainly is still some debate about the designation of late. And I think, we respect that there are different opinions. I think what I would want us to focus on, though, is that there's pretty broad agreement that TDP-43 commonly accumulates in limbic regions in late life aging and when it's a co-pathology with AD. Much work supports this relationship of TDP-43 in these regions with cognition and structural and functional alterations. And so our goal is really to find what are the clinical correlates of that pathology, whatever we call it. And I think that will enhance our ability to understand our patients, to prognosticate, as well as to allow research to advance around this phenomenology. So from a structural standpoint, we'll have some more opening remarks. And then we have 4 primary sections to the meeting today that were based on subcommittees that develop talks and themes. So one is around clinical characteristics, then biomarkers and imaging. Dave Jones is going to give a talk kind of integrating this information, and then we'll move on to genetic predictors and risk factors and clinical trials. And I will end there and turn the floor over to Julie Schneider. Thank you.
That was wonderful. Thank you so much. And I want to thank all the people that you thanked, all the NIA and Pete and yourself and Linda. But I really want to thank Dave, because Dave is the one who contacted me, said, "Do you think we're ready to do this?" I'm like, "Yeah." And that's how this really got started. And I contacted Nina and we ran with it. And so it's really thank you for bringing this forward. It's such an important issue. So I'll get started. I know I have a little bit less time. I can go quickly through this. Here's my disclosures. So I covered a lot of this already. So I'm just going to talk a little bit more what I consider the clinical context, a little bit about the clinical stuff, epidemiology, oil, we'll talk about what we've done in Ross, and some of my things about nomenclature also. So I'm going to take a step back and think about your world, not an academic institution. Domestic and Alzheimer's disease. If you're in the real world, with a domestic dementia, they call it Alzheimer's disease. We know that the burden of domestic dementia is increasing across the world. We know Alzheimer's accounts for
Dr. Schneider,
we know.
Dr. Schneider, there's some problem with your feed over Zoom. It keeps jumping unsupported signal. I don't know if that's an omen, but I hope not.
See, now it's still doing. You can see it right here.
There we go. That one works, Rao. The podium is not working in now. It's causing feedback.
Okay.
Yeah, I have to go to another shot. There we go.
Yeah.
Okay.
We could see here that it was going out. It was flashing. What looks no, it's doing it again.
It's not flashing and I'm not hearing.
You want it on, it's going in and out.
Yeah. So I think for now we'll leave it that we will not use that camera too. So
So
we'll
now-
continue. Yeah.
Now camera 2 is active, so you just stay on camera 3 for now.
Okay.
Okay. Okay, moving forward. So, and as far as TDP-43 in the clinic, it's really unrecognized in the clinical world. People don't know about TDP-43. We know about it. Some of us in the research world know about it. It's growing in recognition, but it's really a largely unrecognized factor. So this is what clinicians do. They see a patient with amnestic syndrome and they say, okay, if it's not Alzheimer's disease, could it be vascular? They do an MRI. They look for some things about Lewy body disease, Parkinsonism. In academic institutions, we know that maybe sometimes it's mixed AD vascular, and then they do the rule outs, right? But they end up calling amnestic dementia Alzheimer's disease. And in spite of this increasing recognition of TDP-43 in the academic world, there's really been no general clinical diagnosis, as Dave mentioned, within the outside world. And even within the academic institutions, if you go to your neurology departments, how many of them are making a clinical diagnosis of late? Not many. So as we started learning about TDP-43 in the brain with the pathology, we noticed that this was a different entity, right? So there's no severe frontotemporal atrophy. It didn't look like FTD. There's no severe spongiform change. There's a temporal predominance, but no frontal predominance. There's a prominent amnestic syndrome without a prominent behavioral abnormalities, and the people are older, as Dave mentioned. And we recognized that unless we do something, people aren't going to recognize or move forward with this. We need it as pathologists to get it out into the real world. And Pete Nelson did that, and our team, big team, in 2019, and came up with a name for it because it's hard to promote something without a name. So why is it important to recognize? You've heard a lot about it's a major pathology in amnestic dementias. I'm going to show you that it has a strong effect size when you look at the statistics, and explains a large component of the variance of amnestic dementias. I'm going to be showing you data mostly from the Ross MAP study, with Patricia Boyle will tell you more about shortly. So this is an older study that we did, Olivia Capacier and myself, looking at, if you look across NCI, MCI, and probable Alzheimer's disease, what the pathologies look like. So focus in on probable AD. So this is a community-based study. We don't have biomarkers. Basically, this is an amnestic syndrome that we think is Alzheimer's disease. And if you look at that Alzheimer's disease, you see that a lot of them have other neurodegenerative diseases. So I don't know if this is the arrow. Is this an arrow? Yeah. You can see where the D is, that's other degenerative diseases. So over half of the people with Alzheimer's have other neurodegenerative diseases in their brains. And only a small sliver just have AD. So this is just showing that there's a lot of mixed pathologies out there. But if we move to those people who don't have Alzheimer's disease, what are the neurodegenerative pathologies they have in their brain? You can see here that a lot of them have TDP-43 in their brain. So this is no AD. Here's TDP, TDP-HS, Lewy body TDP-HS, Lewy body TDP, and here's just Lewy bodies. A huge number of people have TDP-43 in their brain when they don't have Alzheimer's disease. I think we really need to keep that in mind, that it really is a big component. Lewy bodies are there, but it's not as big as it is with TDP-43. So we looked at those people without a pathologic diagnosis of Alzheimer's disease in a community-based study. And we said, well, what is causing the amnestic syndrome in those people? And I highlight here the TDP-43, which is showing episodic global dysfunction as well as semantic memory, as Dave brought up. But you'll see here, and we'll be talking about this today, is that it's not the only thing. So we do have the macro infarcts, and we do have Lewy bodies that are also contributing. So we're not saying those other things aren't contributing, but I do think the TDP-43 was just not being recognized as a contributing factor. We know that the people with TDP-43 are accelerating more quickly if they have Alzheimer's disease. And this was an early study we did. I think there was 120 people in this study, and we were floored at the effect size of TDP-43 and related to decline in function. And within this study, the magnitude of the effect of TDP-43 was equivalent to tangles. So it wasn't a small effect size, it was a large effect size. Another way of looking at it, you don't have to go through all these different pathologies. It's basically saying, what are, between age and dementia, what are the pathologies that are relating age to dementia? And so this is showing a whole bunch of different pathways that we know about. But what I want to focus on is this TDP-43 pathway that was significantly involved in the pathway to dementia. And in this study with pathway analysis, we found that around a third of the pathway to dementia and aging was vascular. Around 2/3 was neurodegenerative, both inside and outside the amyloid pathway. And if you look here, at least in this study, it was more than Alzheimer's disease. Now, I think it's important to know that our age at death is around 90. So we are talking about an older population, and that's probably why it's so high here in the Ross MAP study. But that's a huge amount of huge factor in their dementia. And then finally, I'm showing a picture by Patricia Boyle of a table of a study by Patricia Boyle, where we looked at what is the proportion of cognitive loss based on all the different pathologies we see. So another way of looking at impact. And you can see here, if you combine hippocampal sclerosis and TDP-43, we're merging into the size, the amount of proportion that we see with Alzheimer's disease in people who die at around the age of 90. So again, yes, it's there, but it's not just there. It's really related to, I shouldn't say causing, because we don't know what causes it, but it is related to a lot of decline, fast decline, and has a big impact. And the other thing to point out is that, yes, it is present in a lot of people with a lot of Alzheimer's pathology, but it's not present in everybody with high AD pathology. So almost over a third of people with high AD pathology don't have significant TDP. Around 30% don't have any TDP in their brain at 90. So that's very significant, right? So that not everybody who has AD has TDP. If you look at the intermediate group, even more don't have it. So how much is TDP, as Dave talked about, driving cognitive decline in this group? And then finally, in the people with no or low Alzheimer's pathology, and you'll hear more about this from Pete, there's a lot of people who have TDP-43. So around a quarter of our cohort of people who die at the age of 90 have TDP-43 in their brain and don't have a diagnosis of Alzheimer's disease. If you just have TDP-43, your odds go up of having dementia. If you have AD and TDP-43 together, your odds go up way, way up. And then you can see AD alone is in the middle there. The other thing that I've mentioned is that there's an acceleration of decline. So if you group people and you see the blue line is people with late, the green line is people with AD pathology, and the bottom line is AD with late, you can see those different trajectories of decline in both global cognition and episodic memory across those different diseases. And look at that indolent course of late alone. And I mean, it's really, really different than what we see with AD pathology and what we see with AD with late. So the people who are declining really fast have both. So I'm going to just end by talking, I have a few slides here still, but with talking about nomenclature and why nomenclature holds back research. So nomenclature in neurology is really based on these clinical path studies over the years. And you had a clinical diagnosis, and then it was confirmed pathologically over the years. So you had amnestic dementia, you do an autopsy, and you can confirm your probable AD was AD. If you have hallucinations, Parkinsonism, and fluctuations, you confirm someone has neocortical Lewy body disease. You have strokes and cognitive impairment, you confirm it on autopsy. So we've really lived in this world of confirming things by pathologic diagnosis and really calling things by their pathologic diagnosis by their common clinical syndrome. Common, but not always the clinical syndrome you see with those pathologies. So again, there's lots of different names for things. You can say Alzheimer's disease, Alzheimer's dementia, multi-domain cognitive impairment, and clinical definitions that used to rely just on symptoms. Now biomarkers are evolving, and we're starting to know that we weren't perfect with the name. And we've known that for a long time with path studies, but I think it's just becoming more evident. And we can see this with all of our different dementias, vascular dementia. The clinical definitions relying on symptoms, and originally now you include MRI. If they have a lot of infarcts, you're like, oh, maybe this is a vascular dementia, though we don't have good criteria yet for that either. Lewy body disease, we miss a tremendous amount of Lewy bodies by just using the clinical definition. And then with limbic-predominant, we don't even have a definition. There's no way of even saying you have probable late. So in these other disorders where we have names, how good are we at the clinical diagnosis? And the answer is we're bad. If we make a diagnosis of pathologically of Lewy body disease, neocortical, how many were called Lewy body disease in the clinic? Very few. There's a very low sensitivity, probably because AD is overwhelming the pathology of Lewy body disease. So they're not exhibiting to the clinicians this fluctuations in Parkinsonism early on in the disease. And the same thing happens with vascular disease. You know, lots of times people have both AD and vascular disease. How good are we at saying it's a vascular dementia? We're still working on that. That's still a problem. And then we think to ourselves, okay, well, we used to use hippocampal volume for AD. When ATN came out, N was hippocampal volume or something like that, right? But when you look at the volume of the hippocampus, what's impacting the volume? The two main things that are impacting volume are TDP and AD. So there's a little bit of an effect from Lewy bodies and atherosclerosis, but nothing that comes to any percent that you need to know about. It's really, in older people in general, it's really Alzheimer's disease and TDP-43. And look, if you have dementia, TDP-43 actually is explaining more of the hippocampal volume than AD pathology is. In the no dementia group, the TDP, interestingly, at least in this particular study, didn't reach significance. So ultimately, we need to determine main biological factors based on the clinical syndrome and biomarkers to diagnose, prevent, treat. In the meantime, when it's not amyloid and tau, which we're going to know soon by having these plasma biomarkers, we're going to say, what is this? Is it Lewy body? Is it vascular? If there's no infarcts, or if there's one tiny infarct, is that a vascular dementia? If there's mild Parkinsonian signs, what is the diagnosis? And it's time, I think, and I think Dave was exactly right, it's time to bring this out into the real world as a clinical diagnosis. So to summarize, in the absence of good in vivo biomarkers, everything with slow memory loss and aging has historically been Alzheimer's disease. We have the opportunity now to change things, especially with biomarkers and what we know about these other pathologies, to better diagnose and research the mechanisms of disease and ultimately to treat the disease. And then just a word of caution here is that one of the things I think is going to be happening is as we roll out these biomarkers for Alzheimer's disease, everything's going to be Alzheimer's disease, which it's not. And Dave gave a great example of a person who's amyloid positive, T negative, where in TDP was driving the cognitive decline, or an intermediate amount of T. So we really risk at this point calling everything Alzheimer's disease because A, positive is so common, but it may not be driving the dementia. So we really need to think ahead about thinking about what is the main cause, because if we have different therapies for different things, we may not want to do the anti-amyloid therapies right away. We don't know. I mean, maybe it'll help. Maybe it's downstream. Maybe you won't get the Lewy bodies or TDP-43, but we just don't know. And if we don't actually bin that group, we're never going to know. So I'm going to stop there, and I'll turn it over to Pete. Thank you.
Thanks very much. Thanks to the organizers. It's exciting and very humbling to be in this group of people with such awesome speakers, and the NIH sponsorship is greatly appreciated. I'm not going to go out on a limb and name names like Dr. Volk did, but I totally agree that the ability to biologically change the disease progress of AD is going to put a lot of pressure on us to better deal with non-AD pathologies.
Is it?
Yep. And so, and to do it in a way that's both standardized and data driven. So data has to drive this bus, and I'm going to convey some of that, but you can't do it comprehensively in such a short talk. Great. So just bang, bang.
Yep.
This is,
Yep.
All right, great. So the big picture, and we don't have too much time to talk about very great details, but this is a prevalent condition, and I'm going to show you data on this, that around a quarter of old people are affected by, associated with substantial cognitive impairment and with a recognizable set of pathological and epidemiological characteristics. Unfortunately, before 2019, there had been a large amount of scholarship accumulated over decades, but there was no prior consensus-based effort to tackle this issue, no universal or even common terminology, and it was very underappreciated, very understudied clinical pathological phenomenon. For example, I'm going to throw you a bone here, Dr. Welk. Another one is diagnosis got to diagnose. This applies also to pathologists. I had this every week. We would have cases, and a third of them, we did not have a diagnosis for them. And that is the biggest change. We now have a diagnosis to give patients, families, clinicians. It raised awareness and catalyzed research. I think this thing has been cited 800 and some times, and it's been downloaded 120 some thousand times. It has had an impact in the field, and it has fostered a shared terminology across clinical and research domains. So some progress has been made, but there's also, I think, some confusion in the field and some not completely figured out aspects. And so let's just return to what we all agree on. We all agree on that there is something called TDP-protonopathy. It is misfolded, mislocalized TDP pathology, which is recognized by immunohistochemistry. But it's also been now recognized that it affects dozens of different conditions. Perry syndrome, Alexander's disease, Huntington's disease, all these things have upstream problems that lead to a downstream changes in cells that include this protonopathy that seems to make the situation worse. Quite analogous actually to tau pathology, many upstream tauopathies, but then tau gets in and makes a bad situation worse. And so TDP is one of them. In aging, there's this recognizable pattern that we have sort of distinguished down into a three-stage pattern, first affecting the amygdala, number one, then the hippocampus, then the middle frontal gyrus. One point that I'd like to make is that the middle frontal gyrus is less than 20% of people. So most people don't get it out there, and when it's there, it's at much less density than in FTLD. Another thing I'd like to recognize is kudos to Dr. Keith Josephs and his team at Mayo, who developed the initial TDP-43 staging scheme. It was a very big improvement on prior scholarship. And it highlights the fact that we need a nomenclature that's analogous to AD and AD-NC, where late NC is differentiated from the clinical condition or the disease in abstract. I blew this by Dr. Peterson very briefly, and I don't speak for him, and I'm not putting words in his mouth, but he pointed out gingerly that this has caused a lot of problems, that the AD term, what does it mean? It means different things to different people, and it has caused a lot of confusion. It'd be good to not necessarily recapitulate all that confusion in this later described terminology, but it's really hard to do it without biomarkers. And so it's a hope that this meeting will gin up enthusiasm and specific routes forward for biomarkers for late and that will strengthen the concept. So the confusions, I think, have come with these boundary zone issues with FTLD, hippocampal sclerosis, and AD. All these were terms and concepts that were existing before the classification in 2019, and they have caused confusion. And so I'm going to discuss each of them separately. The big points I'm going to make are that first of all, for FTLD, the pathologies are very different. On HS, most of HS and aging is actually a subset of late. And for AD, I'm going to talk a little bit about the epidemiology of how they co-occur and don't co-occur. And Dr. Schneider has already touched on a lot of this stuff very authoritatively, but so there's going to be some redundancy. So first point is that the pathologies differ quite significantly between FTLD and late. This was a paper in 2020 combining cohorts from UPenn and UKentucky, and criteria were developed, and we had 5 separate neuropathology blind raters to assess them, and we could find with about a 98% specificity whether it was late or FTLD, basically based upon the density of the pathology in the frontal cortex. And this is important to point. You say, oh, so then 2% tweeners, that's horrible, isn't it? Well, guess what? Here's a little memo, a little secret. Most neuropathologies have tweeners, and we have a lot more synucleinopathy and tauopathy tweeners than you might think. Very importantly, this was replicated by an outside group. Dr. Wolk was part of this. They use fancier methods. They use digital pathology and AI and machine learning, but they replicated the essential truth, which is that there are enormous differences between late and FTLD in terms of the pathology. And most pathologists would have around a 98% likelihood of getting one or the other right, just based upon the pathology. So that's FTLD, and I'm going to return a little bit to that. But first, let's go to hippocampal sclerosis. Turns out that most of HS and aging is a subset of late NC. Kudos to Dr. Dennis Dixon, again in the Mayo team, who made the really key observations here. And this are proportional Venn diagrams showing the proportion of people with late and large autopsy cohorts, including ROSMAP, Dr. Schneider's outfit, and NAC, showing that the data are quite compatible with there being a progression from the green to the sort of the brown. The people that are in the pink, which are HS cases outside of late, are a different clinical pathological group, and it's confusing. The terminology stinks, but we're stuck with it. We're calling the same thing, different things, we're calling the same thing. But the point is there's this apparent pathological sequence, which we're going to talk a little bit more about in the genetics portion. And it goes from no late to late plus HS. And so one question then is this part here important? This secondary part of the pathogenetic sequence. And I think it's a little bit like AD goes nothing to A beta to tangles. There are different things that seem to underlie that nothing to A beta than to the A beta to an FT. For example, BIN1 is more in that going from plaques to tangles genetically. So, but is this important? The answer seems to be yes. The progression from late to late plus HS is. We did a big study, came out in Neurology in 2022. Late NC was associated with worse cognition, was not associated with AD pathology or seizures. So seizures is what you commonly think of as a neurologist with HS. It's not an aging. An aging is associated with late and with some degree of cerebral vascular pathology. Dr. Wolk talked a little bit about that, but it's a really interesting concept how that works. Getting now from FTLD to HS to AD. So AD, 2 important points. Each is associated independently with cognitive impairment, both AD-NC and late NC, and they often occur with each other and often occur without each other. And I get into this separately. I want to bring to your attention this paper that published in 2008. It was a multivariable regression-based assessment of all the different things that can contribute to cognitive impairment and aging. This was, Dr. Jika called this everything in the kitchen sink. We threw all of our parameters in, and we were stunned to find that TDP and HS were huge contributors to cognitive impairment and aging. This was the paper that we sent, the second one. The first one got rejected because they essentially didn't believe it. And it's the reason we're here, not the paper, but this observation, the phenomenon that cognitive impairment, if you take into account Alzheimer's disease, TDP and HS are still massive drivers of the cognitive changes. But that doesn't answer all the questions that you'll have. But to address those questions that you have about how things happen in the community really requires community-based or population-based studies. We did this study. This study was done, it's not me, this is a group of 13 huge different outfits including I see Dr. Peterson, the Mayo population-based, Dr. Schneider's Ross map, Dr. Kawas over there with the UCI 90+, 13 very large autopsy cohorts, community-based, large sample size to address this question. The only way you can, you got to bite the bullet and do it. And what we found is that around 40% of people that were in this study had any late. Of these 40%, around a third of them had late stage 1, only in the amygdala, so that's low amount of pathology. But then that leaves this upper right-hand quadrant. And so that is an answer. Around 25% of people have stage greater than 1 late, which is associated robustly with cognitive impairment. But there are still questions. The two big questions that people tend to light on are, does late occur in the absence of AD pathology? And when it does so with or without AD pathology, does it associate with FTD clinical syndrome? Secondly, does it tend to progress to FTLD? Pretty basic questions, but they're not obtuse questions. They're hypothetically testable questions. You can test these questions. We don't have to hide behind obtusity. So we did. We studied that question in the 6,200 brains. And this is not my data. These are, everybody knows what the data are that were in this paper. And many of the people in this study had no neuritic amyloid plaques, none, around 2,000 people. So what about them? What was their proportion with late? We have the answer. This is not a conjecture. Over 25% of those people had late. There's your answer. And if you can maybe get a cohort with 70,000 people from 70 different cohorts, but until you do, this is the answer to that question. Second point is the number of those people with FTD clinical syndrome was 0, zilch. Now, maybe 1 or 2 may have slipped through that had PPA or something, or some disinhibition or something, but as a rule, in community-based cohorts, you don't see FTLD because it's a 1 in 1,000 disease. Every single one of those cases is a tragedy. And I'm so happy that there are people studying them. It's an important disease. I'm not minimizing it at all. It's just a different disease with a different epidemiology. So it's not a question. It's not a question. It's been addressed. The answers to these questions are as follows. Does late occur in the absence of AD or FTD clinical syndrome? Absolutely, yes, it does. Does late tend to eventually progress to FTLD? No, it does not. Those are the answers to the question that have been provided by science. So human phenomenology, I'm almost done. Late is not pre-FTLD. FTLD is horrible. Glad that people are studying it. It's a different thing. It's pleiotropy going on. MAP-tau provides added oomph to PART and to AD. Certain genes provide added oomph to both late and FTLD. That doesn't mean that they're the same thing. They're completely different clinical pathological syndromes. Late NC factors promote HS. We don't know how that occurs, but it's a really interesting question that we're going to talk a little bit more about later. AD NC factors, and this is analogous to sort of synucleinopathy. Synucleinopathy is synergistic with AD, and so is late. About 50% of AD cases are late. Of people that have no AD, though, around 25% have late. This is exactly as Dr. Schneider said. And after age 75, the x-axis here is time and age is cognition. This is exactly what Dr. Schneider showed. This is going to be a recurrent theme of the day. No pathology is flat. Pure has decreased. Pure AD has more. The combination is worse. The kicker, though, from the epidemiological perspective, is that that's also the order of prevalence. Pure late is very common. It's about 1 in 10 lifetime risk. More prevalent, though, is pure AD, and more prevalent still is the combination, which has the most malignant progression. And very much kudos to Dr. Schneider, who made the key discoveries, and you have to use a community-based cohort to make these discoveries. So I conclude that late is very prevalent, recognizable pathology and other characteristic features, often occurring in combination with other common pathologies in human brain aging. I'd like to say thank you especially to our patients and to the people under whose care we try to help. And so thank you.
So I think originally we had a little bit of time for discussion, but maybe we should move to the next section with the next two talks around clinical characteristics. And then after that, there's a 20-minute or so discussion period built in that we can address any of the talks that have already been done. So the next talk is by Patricia Boyle and Tan Hao Wang from Rush University, and really look forward to what they have to say.
First, I'd like to thank the organizers, thank the NIA. Thank you, Linda. I haven't met you, but you're clearly critical in this meeting, so appreciate the invite to be here today. I would like to also start by just acknowledging that while I'm the face you're going to see for the next little bit, this work really reflects the hard work of my close collaborators, Lei Yu and Tian Hao Wang, who are with us on Zoom, and they really did the heavy lifting for this work that I'm going to show today. And on top of that, they put up with me on a daily basis. So that being said, all credit to them. So today I'm going to kind of go through three different areas. First, I'll just talk very briefly, because you've already heard a lot about this, about what we know about the impact of late on cognitive outcomes, what we know already, what the prior research has shown so far. Second, I'll address the question, does late have a specific cognitive profile that we can use to support clinical diagnosis and detection? Here we're going to get into some new stuff, and that's really the meat of the presentation. Then finally, we'll talk about some diagnostic challenges and future opportunities in this area. So as Julie mentioned, most of the data I'll be showing you are coming from the Rush Memory and Aging Project and the Religious Order studies. These are studies that I know a lot of you are familiar with. For those who might be on Zoom or are not familiar, they involve more than 3,000 community-based older persons. All begin with us when they are not demented. And we follow them annually throughout their life until they die, at which time we collect their brains so we can relate what we find in their brains to their cognitive and other trajectories during life. So they undergo detailed annual clinical and neurologic examinations. Most important for what I'll be talking about today is that all participants have 19 cognitive tests done on them every year. These tests can be used to support a summary of global cognitive function, as well as 5 specific cognitive abilities. And you'll hear more about that in a moment. We also, as you know from Julie, have very detailed data on multiple degenerative and vascular pathologies, as well as in an ex vivo imaging data, which also provides another window into what is happening to the brain as we age. So all of these data points allow us to take a very systematic and comprehensive look at what is driving cognitive decline as we get older. So you've already heard pretty much all of this, so I won't really review it. We know that late and AD are common. Like AD, late is strongly related to dementia risk and cognitive decline. They have additive effects, and most prior work suggests that late does preferentially affect episodic memory. Julie showed this slide, so I won't go into it in details. You know, TDP alone is associated, or late alone is associated with an increased risk of Alzheimer's dementia. AD is, of course, a more potent risk factor for Alzheimer's dementia. I don't think that surprises anyone in this room. But what I want to point out again here is the additive effect here. When you have AD with late, we see a real jump in your likelihood of developing Alzheimer's dementia. This is some results from a study that Bob Wilson did in one of our earlier papers, looking at the impact of late on cognitive function, in particular, different cognitive systems. And as you can see here on the top line, late has a very profound effect on episodic memory. Here, Bob Wilson was looking at change in episodic memory over time using, and other cognitive domains, using linear modeling techniques, so that he's looking at the degree to which late is related to the straight line change in cognitive function. We do see a small effect on working memory here, but as you can tell from the estimate, the association of working memory and late is about half that of late and episodic memory. So it's not of the same magnitude. There's something different going on. Now, there have been several studies. Julie showed one by Olivia Kapasi, and others in this room, as well as our group, have shown these similar findings since this time. But one important caveat is that essentially all of the prior research has modeled cognitive function using linear approaches. It's now very clear that the trajectory of late life cognitive decline is nonlinear. In the years prior to death, we see that individuals show a sharp decline in memory or in thinking abilities, memory and other, and we call this phenomenon terminal cognitive decline. Now, it's essential that we take into account nonlinear cognitive decline in order to really understand both the natural history of cognitive aging, but also the impact of various pathologies on cognitive trajectories. So our challenge here is to ask the question, does late have a specific cognitive profile that we can use for clinical detection? We enjoy in these studies the benefit of very long-term cognitive data evaluations spanning up to 24 years that really allow for a detailed investigation of cognitive decline and specific trajectories, as well as more than 1,400 brains with detailed pathologic data. So currently we're using very novel statistical approaches to characterize cognitive decline and understand the impact of pathology on various trajectories. In particular, we're using something, I won't go into detail here because this may not be the right audience, but it's called the functional mixed effects model. And there are just two key features of this that I want to point out. The first is the functional mixed effects model is a very flexible model that accounts for nonlinearity in cognitive decline and essentially allows the data to determine the shape of the cognitive trajectory. So we're not imposing any form. We're letting the data show us what is happening over time. And again, this is really essential to truly understand the profile of cognitive aging. In addition to that, the FME models allow for time varying effects. So they allow that the association between pathology and cognitive decline may change over time. There's no reason to assume the association between pathology and cognitive function is static, right? So this gives us the flexibility to address that directly. So today, using this approach, I'm going to be showing you some new data. These are not published data, hot off the presses, on the impact of late versus AD on decline in cognitive systems, with the hope that these findings will shed some new insights or add to the insights that have already been presented here regarding the cognitive profile of late. So first, just to orient you, I want to show you what cognitive aging looks like in our studies in general. The black line here shows you the mean change in cognitive function over the course of the study, from the beginning of the study to the end for the whole cohort, okay? Not adjusting for pathology or anything, just what it looks like as we follow people going forward. Couple of things to note. Around the mean line are individual trajectories. All those other lines are someone's personal profile over time. You can obviously see here, there's tremendous heterogeneity in cognitive function. Cognitive aging is not one thing. I think we all need to really, really hone in on that message and understand it. It's a complex process. But number two, if you look at the black line, you can see clearly that there is nonlinear change. Cognitive function in the early phases is relatively slow. It's not a sharp line. But as we progress through the study and the aging process, cognitive decline begins to accelerate, and we see that more rapid deterioration in function. This, again, is critical for understanding the trajectory. Now, so what I'm going to show you now is the impact of late versus AD pathology on cognitive function. When we look at this for global cognition, here's the profile. So the red line is the mean line of change associated with late, and the black line is associated with AD. Now, a couple things to point out. The reference here is individuals with no late or AD, okay? And so, and the shaded areas are the confidence bands, of course. So when we see those confidence bands moving away from that green line, that indicates to us that individuals with these diseases are now behaving differently than those without these diseases. So in terms of global cognition here, you can see right from the beginning of the study, at enrollment, both individuals with late and AD are showing a lower level of cognition than those without. They're already dipped down before we even got them in the study, really, right at the start. Over time, though, we see progression of cognitive decline. The progression is faster for those with AD, as you can tell with the black line, than those with late. So it's slightly slower for those with late. But I will point out that the confidence bands, as you can see, overlap, suggesting that they're not significantly different in terms of their rate of decline. However, the profile, if we just observe the profile, we do see this slower pattern of decline, which I think is consistent, Dave, with some of the clinical findings that you were discussing this morning. Now, when we look at the profile of late versus AD across domains, let's just focus on late for a moment. Here, what we're showing is the rate of decline associated with late, all 5 domains in this model. And on the bottom, so the solid red line is change in episodic memory. The gray line is change in semantic memory. Black is global cognitive function. And then we have the other domains above. I mean, you can clearly see the preferential effect here on memory systems. Okay, late is predominantly affecting memory, although it is obvious that other domains are coming on board later in the course of aging. Okay, so it is not an only amnestic syndrome type disease. It's just it's a timing thing. Predominantly memory declines earlier, but other systems do come on board later. Now let's look at AD. If we look at these two figures side by side, you can see that they're very similar. So the profile of AD is essentially the same. Predominantly memory declines more and faster, but other systems do come on board. We can see that they're coming on board earlier than in the case of late, as they're breaking away from that green line earlier. But again, overall, if we look at these profiles, they're very similar. Now I want to break it down a little bit more in terms, just to give you a sense of how we understand this at the cognitive system level, to really kind of try to flesh out the profile, since that's what I've been tasked to do today. So if we look at episodic memory, again, like global cognition, we can see that right from the beginning of the study, those with late and AD are starting at a lower level. They show progressive decline over time. Again, late slightly slower than AD. Overall pattern is the same though. Same story for semantic memory, although it starts slightly later. Again, a slightly more rapid course for those with AD and slower course for those with late. But again, overall, same pattern of change. Now, the story gets a little bit more interesting when we go into other cognitive systems. So here, on the left, you're looking at decline in perceptual speed. So in this case, you can see that gray band breaks away from the green line around 1 year after baseline. So we're seeing changes in perceptual speed beginning very early on among those with AD pathology. By contrast, the timing of the onset of change in perceptual speed for those with late starts a bit later, around 9 years. So again, the pattern you see overall looks similar. There's a slightly slower decline for those with late, but there is this temporal difference in timing. Similarly, for working memory, we see earlier evidence of impairment and decline in working memory for those with AD, but again, about 5 years, at 1 year, but again, at 5 years, we're seeing that same decline for those with late. And again, overall, the pattern looks similar, but those timing differences, are something of, I think, to take note of. With perceptual orientation, also known as visuospatial abilities, we see a similar pattern. Those with AD are affected right away at the outset of the study. We're already seeing they're lower. They have a pretty progressive decline throughout the study. We don't see that clearly in those with late until about 6 years into the study. But at that point, again, they start taking the same course of change over time, and there's decline over time. Less so than obviously the memory domains, but you can still see it there. Now again, though, we do have timing differences, and those are notable, and we can talk about those. But overall, the profile of late and AD do look very similar. And again, Dave, I think, the epidemiologic story is really mapping on well to what you have seen in the clinical setting. So the take home so far is that we know late affects memory earliest and most markedly. However, over time, other domains are affected. But when we think about late and AD together, we really see similar cognitive profiles. Although the effects on non-memory abilities may come on board later for those with late compared to AD, the overall pattern is very similar. And I think, that really is going to present a challenge in the clinical setting because, it's very hard to determine things based on a timing of sequence of events. We know that even Alzheimer's patients have very varied courses. People can have, slower or faster courses involving more or less domains. So, this really is gonna raise some issues when it comes, to using cognitive data for clinical diagnosis and detection. But I think there is hope. There are still lots of opportunities for the future, in particular biomarkers. So and I know we're going to be talking a lot about this later, so I'm just going to get into this very briefly and show you some quick findings. This is a study done by Lei Yu looking at the relationship of various brain pathologies with hippocampal volume. On the left column, you see the volume size for an individuals with no pathology. Their hippocampus is looking good. Then next to that, you see AD. Of course, we see a decrease in hippocampal volume among those with AD, as expected, of course. But in the third column, you see late. When late comes on board, now we really see a significant drop in hippocampal volume. Late plus AD is slightly lower. We might have expected it to be a little bit lower than that, but suggesting an important role for the hippocampus in late as well as AD. Dr. Lei Yu is also doing some mediation work to look at whether hippocampal neuronal loss might explain the associations of either tangles and or late with cognitive decline over time. And if you look at the indirect effects here, you can see that for neurofibrillary tangles, neuronal loss really isn't doing much to account for the association with cognition. So the indirect effect is only 7%. So that's not explaining the association between tangles and cognitive decline. By contrast, among those with late, neuronal loss accounts for about 50% of the association between late and cognitive decline. Again, supporting this idea of an important role for the hippocampus in late. And finally, Konstantinos later on is going to give you more details about this, but there are other approaches that we can use to investigate hippocampal indices and function and structure, one of which is surface deformities. And Konstantinos will get into details, but there's some evidence that changes in the structure and surface of the hippocampus are related, particularly in certain ways, to late. So in conclusion, we all agree that late is a very important determinant of cognitive decline and dementia in old age, but it's going to be difficult to distinguish it from AD and probably other ADRD syndromes using only cognitive data. Late and AD share very similar cognitive profiles overall. When we take a big picture approach and we look at the whole life course of aging, we see that they look very, very similar. It's going to be hard to distinguish those. I think examination of other behaviors may be important. So for example, We have some data, I think you mentioned financial decision-making in your presentation, Dave. We study financial decision-making as one of our behaviors, and we do have some data suggesting that late does preferentially impact financial decision-making. So it may be that we need to back up and look at some more complex behaviors or even other non-cognitive behaviors that really have not been well investigated yet. But I think biomarkers in this context likely are going to be the key. And I say this with some remorse because I am a neuropsychologist, and traditionally our role, of course, has been to provide evidence of a cognitive profile we can use to distinguish syndromes. But I think late is its own entity, as Pete eloquently described, and we're going to have to deal with this, and it's not straightforward how to do this on a clinical level. So integration of different sources of data is clearly going to be key here. So thank you, and I just want to acknowledge real quick Julie Schneider, of course. Her footprint was all over everything I just showed here. She's a very close collaborator and friend of mine. So thank you for all your input, and thank you all for your attention.
That was great. We'll go on to the next talk, and like I said, we'll have time for discussion after. And so the next speaker, who needs no introduction, is Claudia Kawas, who will tell us about a lot of her work in the 90+ study and how that relates to this conversation.
Yep. This is pointer, and you can.
Thank you. Well, thank you. And like everyone, I really thank you for inviting me. I'm enjoying this very much. And I actually, the organizers and NIA, but I also especially want to thank Patricia for just doing all the heavy lifting for our session. So, and I am, I think all this work is really important and interesting. I'm going to take a slightly different view and suggest the possibility that we already have clinical criteria to identify late. That doesn't mean we should stop working, but today I'm going to talk to you about the prevalence and malignancy of late. And I have a feeling not very many people are old enough to recognize what my title is referring to. But I'm starting to realize there are a ton of advantages to getting older. So this is not advancing. Can I try something else? I try. My hand holding isn't good enough. So I'll start talking. Who really needs visuals anyway? Is this am I close enough to the microphone?
You can use.
Thank you. Okay. I'm going to begin with some historical musings on defining a disease. To me, the public health process is first you define a disease, then you develop you understand the key determinants or the risk factors of that disease, and you keep taking the process to eventually, hopefully, finding treatments and putting them out into the community and public policy. But for late, we are back at the beginning of that process, and I think today what we are essentially doing is continuing our work in defining a disease. I'm old enough that I watched another disease be defined, so you'll hear about that first. I'm going to talk a little bit about some of the findings we have in the 90+ study, which are just a smaller version generally of what you just heard in the Rush Ross map individuals, and a couple of other interesting things that have been popping up. And then I'm going to make some comments about neuropathological changes and the fact that they don't occur in isolation and what we should be maybe using as an opportunity. Mostly I'm hoping to talk about gaps and opportunities and finish early and let everyone discuss. So in 1970s, Merit Textbook of Neurology, and all medical students like me in that decade learned that Alzheimer's disease and Pick's disease were rare, they were pre-senile, and that I would probably never see a case. Until essentially in 1978, Bob Katzman defined a disease, the disease that we have all been studying now for the last 40 years. It was a 2-page editorial entitled The Prevalence and Malignancy of Alzheimer's Disease. It rapidly became the most cited AD publication. Of course, this was in a time when, in all fairness, he would run a PubMed search every year and read every single paper that was about Alzheimer's disease. And in those days, it was in the hundreds. And as you can imagine now, I mean, most of us can't even count. Over the next few years, the National Institute of Aging happened. They started the first ADRCs, which were awarded in 1984. And also at that time, they organized us in terms of doing a criteria for Alzheimer's dementia, which rapidly became the most cited publication in Alzheimer's research probably ever and forever, since it's up at 33,000 and counting. It goes into all our papers, it goes into all of our grants, and this criteria allowed us to do those 33,000 papers, right? It was very important to have this clinical criteria, even though at the time it seemed awfully simple. I mean, most of us felt like we kind of knew Alzheimer's disease when we saw it. I mean, the joke at the time was it's like pornography. I don't know how to define it, but I recognize it when I see it. And the criteria, though, turned it into this definite, probable, possible thing that we now superimpose on almost all things. But in all fairness, it allowed a huge amount of progress. And even at the time, I think if anybody thought about it at all, they realized that that doesn't mean that everybody who fit into the criteria had Alzheimer's disease, because they didn't. And we now, can even quantify that at least a third of the individuals who fit into those criteria are amyloid negative. And so they get kicked out of the Alzheimer's bin. But I really want to make the case that that should not be the only criteria for getting pushed into the late bin, right? But this is a way that we can get our acts together to do some work. And at the moment, Alzheimer's disease, which has had a whole lot of clinical research, those of us who have gone through it don't feel like we can do late research without clinical criteria. Unless you have a huge clinical path database and you have waited for these individuals to die and now know they have late, we feel hampered without a biological marker. That criteria did as well for 25 years, and then it was updated in 2011, and most of you know that the main thing that did was add the idea of mild cognitive impairment due to Alzheimer's, or even preclinical Alzheimer's, and in particular, how biomarkers would be added to the clinical criteria for dementia and for these conditions. And then we have a lot of biomarker development, and the NIA research framework for biological definition, which is the one most of us are using now, and using all these markers that are coming out daily of all different sorts, both ones that are specific for AD and ones that aren't. So that was a half century of progress I just went through. Late, 4 years of progress, only if you're stretching it. But I think that we got the definition of the disease in certain ways, the pathologic definition certainly in 2019 with the paper that everyone is talking about. 3 years later, there was a modest update of that path criteria. And throughout this period, everybody has been saying, where's the clinical criteria? And I'm a chicken, so I'm glad that David and others are going into the fray with much more aggressiveness. Today we're having this meeting, I think, to define this disease. And we know that our definition is not going to be perfect, but what we want is a definition that is going to enrich a population that we can then study clinically until we get the biomarkers, which hopefully are not going to take a quarter of a century this time, even though I recognize that TDP has a whole lot of challenges compared to amyloid in terms of identifying biomarkers in any way. So, First, I'm going to talk about the age, risk of dementia and attributable risk, which is just another way of saying what's the prevalence and malignancy of late in the 90+ study. So nothing comes close to age. Age is the primary risk factor. Everybody is often talking about how we see most of late after age 80. In the 90+ study, we started age 90, and we see more than a third of them have late at autopsy, and the number increases to over 40% for the centenarians. And age is the strongest risk factor, by the way, not only for late, but it's also the strongest risk factor for Alzheimer's disease. And the curves are shifted, as I think, Patricia just showed you in a lot of ways. But I don't want to forget that actually late does occur before age 80. And in work that Ahmad Sajadi has not published, you can see a graph here where a quarter of participants in NAC who have late are under the age of 80. And you can see there's quite a few people even down in the 50s and 60s, which are, by the way, not FTLD patients. So late is strongly related to age, but can occur in younger people. Sex and education, at least so far, appear to not be clearly related in our or any other data set that I'm aware of, and we really don't know about race. When I started the 90+ study, California, which is a very diverse state and was even then, only had 12% non-white individuals over age 90. I'm hoping in our next round to recruit a new cohort, since that has now increased considerably over the last 20 years. But in the literature at present, the only paper I could find, God bless Rush and Dr. Nag, almost everything I find is coming out of there. There appears to be no difference in the sole paper I could find comparing Black and white individuals who come to autopsy. So late, at least so far, doesn't have any clear racial difference, but is certainly a gap we need to increase and take a look at soon. Now, in the 90+ study, I've said for about 2 decades now, probably, that if I have to have something in my head, please make it be Alzheimer's disease. And the reason is because when we look at the odds of having dementia in relationship to all these pathologies, you can see that anybody in our study who only had Alzheimer's pathology, no other pathologies, at least that we identified at the time that were of significant level, there's a 50-50 chance that they have dementia. But that wasn't true of most of the other pathologies. And the odds of having dementia in the presence of TDP-43, as you can see, is over 3 compared to the odds of dementia for AD, which is only 2, or Lewy bodies, which is down in the same range. And sometimes you can add the HS and TDP together, and you can see that they coalesce in a way. I also want to point out at the end of this graph, this is a topic for another meeting, but it's going to be one of my pushing interests for a while. We never talk about how much athero or arteriosclerosis contributes to dementia. We talk about vascular and we talk about strokes of all sizes, but in fact, having severe atherosclerosis or having any level of arteriosclerosis in the brains of our participants greatly increases the odds of having dementia beyond, at least at a level of what Alzheimer's does, and at a level of what TDP does, and at a level we've ignored. I mean, everybody has known for decades that in NAC, for example, every Alzheimer patient brain, more than 50% of them have vascular disease. And we say that, but then we act like everything we're studying or everything we know about that individual has to do only with Alzheimer's disease. It's, we're ignoring these combinations in ways that I think is a good opportunity now to rethink. So when you're talking about odds and risk and prevalence, I think, we get some of these things confused. Prevalence is how often do we see it? We see Alzheimer's pathology in our brains twice as likely, twice as often, 70% or more compared to late, which is 30 to 45%. But the real question is, when you've got all these pathologies, how much dementia is being caused by each? Or one of the ways I like expressing it is, if I got rid of everything, if I got rid of every single plaque and every single tangle in the 90-year-olds that I'm studying, how much dementia would I get rid of in this cohort? And this is work done by Maria Carrata, who does all the hefty lifting and when it comes to things I'm interested in, and unpublished as yet. But it turns out that when you put it together, this is what you get. So as I said, vascular, which is a bunch of things all lumped together, we're going to ignore on this meeting. But I think what I want to direct your attention to is Alzheimer's pathology may be in 75% of our brains, but if I got rid of every plaque and tangle in these individuals, I'd only be getting rid of a quarter of the dementia. And one of the things that I'm really hoping in the next few years is that our entire field will start sending some sprouts out for the other 75% of dementia that we have pretty much ignored for the last 40 years. And following right on the heels of Alzheimer's disease is late. It accounts for almost 20% of the dementia in our cohort. Add to it HS, and it even takes you up there. So it's a big chunk of dementia and a big target that I think we can now hopefully, do our take a look at and see ways in which we can help this. So the way we kind of help these things usually is, what are the key determinants, the risk factors? This gives us clues for the disease, and we go looking for these things. And here's a couple of, I think a lot of people are turning over their data sets to find things. This is work by Ahmad that was just published fairly recently, and we turned over all the past medical history rocks in our data set, most of which did not show any obvious relationship, but compared to individuals, it looked at people with osteoarthritis. This is all by history, self-report, and people with a history of hypertension actually have a lower likelihood of having late in their brains. And this is particularly fascinating in some ways to me, because we also, as many people have shown, in the oldest old cohort, i.e. nobody ever finds it down at the 50 or 60-year-olds. There we say high blood pressure is a risk factor for dementia, but it's been fairly well established that once you get into the oldest old, which is where late becomes very common, as well as AD, that in fact hypertension appears to be protective for dementia in our cohort, and at least this is one of the pathologies that it has the potential to be working with. Now, why hypertension would be related to late, whether it's a medication effect or a perfusion or a whatever, certainly remains to be seen. But I think it's an important thing that we've known about for a long time, and maybe it's more specific to late than it is to other pathologies. Anxiety didn't survive multiple corrections, but it's in keeping with some of the literature kind of trying to look now at behavioral and other non-cognitive profiling of individuals to identify what might be more related to late. This one was also recently published. So I think estrogen has haunted my entire career. I have never been interested in that kind of thing. And I have all kinds of papers that I didn't really want to publish that are in the literature, some of which say the opposite of the other things. But this one I thought was pretty fascinating. So we have in the 90+ study, the original 1,600 people who were enrolled were members of the Leisure World cohort. That means that in 1981, they all lived in the same city, and they all filled out a 14-page questionnaire where they told us a bunch of stuff. And the USC investigators who started it were particularly interested in estrogen. So there's a ton of menstrual-related reproductive factors and estrogen use data in there, as well as some information about dietary intake and supplementation of vitamins A, C, and E, and just some stuff about exercise and all sorts of. So we took a look to see, is late related to, it's not related to the vitamin story, and that's another one we can talk about later. But I was really surprised and think this is a very provocative potential result. I'm hoping maybe somebody can see if they can replicate. And the idea is that women who in 1981, when they were in their 50s, 60s, and 70s, and were answering and giving what their menstrual and replacement theory was, I'll point out that given the time, most of this is unopposed conjugated equine estrogen. Right? This is mostly Premarin because that's what women were being given in the 70s and 80s when they were reported, when these 90-year-olds. And so for individuals who took estrogen and died in their 90s, their risk of having late was lower on autopsy and substantially lower. You can see it's a 60% less likely for long-term users and for recent users. Recent users means at the time they filled out the questionnaire in the 80s, no matter what their age was. So maybe some of the signals that we've been finding for many years with regards to estrogen in relationship to dementia in women, and these have been mixed signals for sure, where all the observational data suggests that it's protective, but then we do a clinical trial, and I'm not sure what happened, except we got prematurely shut down largely on the basis of WIMS data. But estrogen has a lot of stuff in the literature suggesting it's protective for dementia, and maybe in fact, this is one of the things that it's related to, but of course needs to be replicated. Congestive heart failure was proposed as one of the earliest papers, once again from Rush, who found that it and early signs of motor features were also associated with a lower risk. I'm not aware of anybody who's identified anything associated with a higher risk, but I'm sure there's some things to be found. This is a gap and an opportunity. And I thought this article was very interesting, suggesting the possibility that lifetime lead exposure. No data here, but we all know that lead exposure has gone down over the decades. We also know that for reasons which are unclear and have nothing to do with amyloid antibodies, that it appears the risk of dementia has gone down over the last couple of decades. And there might be other exposures, including things like lead, that have gone down over time that are resulting in this. And TDP's biological plausibility in relationship to lead was also explored in this article. So I thought that was really an interesting thing to consider. And we've kind of left this behind. I think we need to go back out and see what out there in the world could be related to these. So everybody always brings up that you put late and you put AD together and you decline twice as fast. In our view, kind of you put anything together and you decline twice as fast. The number of pathologies is absolutely due to the likelihood of having dementia, and it's also due to the severity of dementia in our studies. But in our hands, it kind of doesn't seem what you're combining. And so for the most part, we've treated these as additive. There's multiple pathologies. You have the bad luck of having, more of them, you're going to do worse because they kind of add together, and that's mostly fitting the data that we have. But here is one of the things I really think we have ignored, and that is that it's not just that these pathologies occur together, but they tend to occur together with specific combinations happening much more often than others. And I don't think we think about enough and what that might be telling us. So in the case of late, we know that these are the pathologies that they coexist with. Certainly everybody understands high degree of Alzheimer's disease, 50% will have late. But we also know that no Alzheimer's disease, 25% will have late, and in the 90+ study. I originally thought that TDP, that late and hippocampal sclerosis were going to kind of be the same disorder, because everyone made it sound like that was what we were going to find. But now, once again, it's sort of like 40% or so in our hands of hippocampal sclerosis is not late positive, and vice versa happens even more often. Lewy bodies occur very infrequently in our 90-year-olds, and nonetheless, we were able to find the relationship that has been found in many other data sets relating it to late, which nobody ever talks about. I mean, what's going on with alpha-synuclein, and why is it coexisting with TDP in these brains? And finally, vascular factors. Once again, we really need more attention to understanding how things, specifically in the case of late arteriolar sclerosis, is highly related. And in our data set, we looked at those things independently, so I understand that these things can be related, but even by itself, arteriolar, and it occurs more commonly than we think it should with late. So I'm not sure I need to summarize most of what you've heard in the last 3 talks, which is that late's common, it's highly associated with age, it accounts for about a quarter or so of dementia, especially the older you get. We don't really know the protective or the risk factors, but I think there's a lot of work that can be done there, as well as exposures. And I don't even need to say, of course, we need to move to a biological framework. We need biomarkers of some sort for TDP and late that will at least enrich our samples, if not give us a definitive biological definition. So, gaps and opportunities. I think we can look more at the clinical, but as Patricia said, in a way, I think we have criteria that identifies late. It reads remarkably similar to 1984, McCann et al. Even in that publication, it was demoted to possible too. Possible Alzheimer's disease was an isolated amnestic response problem, essentially. I mean, we kind of know what late looks like. What's driving us crazy right now is that the definition we have been using for Alzheimer's disease, and does a pretty good job of capturing Alzheimer's disease, does an equally good job of capturing late, right? So maybe what we really should be talking about is, I mean, we do say we can pull the Alzheimer's out now with an amyloid marker. I don't want everybody left behind to be late, but I do recognize that from a statistical standpoint, the way it used to be with Alzheimer's disease, if you knew nothing about diagnosing dementia, if you said every single patient had Alzheimer's disease, you know, you'd look really good, right? So if we take all the amyloid negatives and call them late, we'll look pretty good, actually. I think that's what we just realized. But the bigger group is the overlapping group. And that is one of the things I really think we should look at this as an opportunity. Our entire conceptualization of dementia right now is, I've got one protein that I don't like and it causes hopefully a syndrome I can identify, and at the end of the day, a treatment. And somewhere along the line, I'm going to have to give you a cocktail that'll get your amyloid and get your tau, and now it's going to have to get your TDP, and it's going to, you know, I think that we are missing something about, as we consider these as multiple pathologies and that are just co-occurring. I think there are probably upstream mechanisms that make certain of these coalesce that might be targets we need to develop. I think a lot of people are thinking about these things, but I kind of like to focus our conversation around them, because in the end, I really think it's going to be an important thing for us to do. I want to emphasize diversity. We need diversity in our research participants. I'm hoping to go forward maybe with, if we get funding, and bring in diversity cohort, but I also want to make note that Maria Carrata and Rachel Whitmer and Paolo Galans have 1,000 people enrolled in Life After 90, which is Hispanic, African American, and Asian diversity cohort of individuals using somewhat similar methods to the 90+ study, which is mostly white. And I want to put in a plea for reliability, please. I mean, I think even at this point, we're starting to get some numbers out of different cohorts. And I don't know if the reason why it's 30% in one and 40 in another and 50 in another is really because of the cohorts or the ethnic makeup of the cohorts. But rather, I think that, as I think Pete once said, we've spent a lot of time talking about the gold and the gold standard, but maybe we could talk a little bit about the standardization of the gold standard and the reliability of the people who are looking and doing these measures, as well as in the clinical realm. So it takes a village. I can't even put the number, but I want to thank especially Maria Carrata and Ahmad Sajadi, who's been working on late as part of his R01, and all the people who help us do this, but especially the participants and their families and the National Institute on Aging, without whom I'm nothing. So, thank you.
That was awesome. Thank you, Claudia and other speakers. We have about a little over 10 minutes for Q&A. Obviously, built in the rest of the day, there's some more discussion time, so we can come back to things. And then the only other thing is, I know there are people on virtual who also might have questions as well. So will we be able to?
Yeah, I have the questions. Dr. Boyle, if you don't mind maybe moving over to here, so because the camera's already on that, because a couple of them are for you as well. Thanks. So I think we can start with Dr. Woke. This one is from your presentation. The one, I think it was the first brain image you showed, Andrea Bozzocchi saying shows not only medial temporal atrophy, but very significant global cortical volume loss. If late is limbic predominant, what is driving the atrophy in the rest of the cortex?
It's a great question. I'm not sure I have the answer in that particular case, who had very low level AD and had also had no Lewy body pathology as well. I mean, there are these sort of brain age related changes that we also see in terms of structure that don't necessarily have a completely identifiable pathology associated with them, or at least that's been discovered yet. And so certainly that might contribute as well. Perhaps other kind of network related changes may also occur, but I don't think we have a great answer in many of those cases, why the brain has cortical thinning and a variety of regions is just part of the aging process, dissociable from underlying sort of definable pathologies.
And a related question from Mark Baxter. I don't know who this is best addressed to, maybe Julie or Pete. Given the involvement of the amygdala, is there any notion that there are changes in affect and emotional function in late, maybe as an early clinical sign?
Yeah, I think as Patricia pointed out, we are interested in behavior, and I know that there's a lot of people in the audience who are interested in the behavioral changes that may occur. The thing about the amygdala from a pathologic standpoint, and Pete has a paper on this, it's really a hotbed of proteinopathies. So we see tangles in the amygdala early, we see Lewy bodies early, we see TDP43 early. So there's a lot happening in the amygdala, and teasing out these early behaviors is something that is, I think, a work in progress for all of us, to really start looking at these higher cognitive functions and emotional functioning. I know that Dave has some ideas about what might be changing specifically in late as far as behaviors.
Yeah, I mean, I think when we think about, again, looking at the staging of the pathology, you're certainly affecting networks that are going to be involved in some aspects of, emotional processing. That moves into insular regions, orbital frontal cortex. And so, to some extent, even though, I think quite rightly we're dissociating a typical FTLD spectrum from these cases, there's just like any neurodegenerative disease, its anatomy matters. And, where there's pathology is going to influence, the phenotype that we see.
Dr. Rabinovich, would you like to unmute and ask one of your questions?
Sure, thank you. What a terrific morning. Can you hear me?
Yes.
Yep.
Yes.
Okay, great. Really amazing talks. I'll ask a question. I think this is for Peter and Julie. So we heard that in these amnestic predominant presentations, there's not much contribution from synuclein and not much maybe from vascular. But what about other limbic predominant age-related pathologies like PART or argillophilic grain disease? How common are these? How much do they contribute to these late life amnestic presentations? Is it really all AD or late, or should we also be thinking about PART and AGD?
So I can start, and Pete, you can chime in. So if that one slide that I showed where we looked at our people without Alzheimer's disease and looked at their episodic memory, indeed, it wasn't just TDP-43 affecting episodic memory. Vascular pathology was significantly affecting episodic memory, as well as Lewy body disease. So we know both of those are contributing. Interestingly, if you look at the group in that particular paper where we said, okay, how about the AD pathology that's not reaching the threshold to become Alzheimer's disease? In that particular paper, it was not related to episodic memory. So at least in that subgroup, sub-level tau pathology in the hippocampus was not contributing to their episodic memory. We're looking at that more closely now, and there's other neuropathologists who are. There's certainly a relationship, if you look at our overall cohort in primary age-related tauopathy and episodic memory. It just never reaches the degree that we see with Alzheimer's disease or TDP. And then also you'll hear about this from Konstantinos later, I think. In our study looking at hippocampal volume, those other pathologies did not reach any significance. It was really hippocampal sclerosis and or TDP and AD that's affecting the hippocampus itself as far as that atrophy. So I think there is a contribution. I just don't think it rises to the level of what we see with TDP-43 or Alzheimer's disease. Pete?
So I agree with everything that Julie says, as usual. I also endorse very much Dr. Kawas's point that we have to think about these combinatorial processes and these proteinopathies happening together. One point that I would magnify a little bit is the point of the combination of AD would have plaques and tangles as well as synucleinopathy as well as late. That combination seems to, when you include younger subjects, to be something that does affect younger people with a more aggressive course and to have a very common side effects of delusions, hallucinations, psychoses. So when you see somebody who's 75 going down very fast with delusions, hallucinations, psychoses, that is very common. This QMP, quadruple misfolded proteins with A beta, tau, synuclein, and TDP. The overlaps, though, are numerous, including the pleiotropy, that the same genes that are affected with late are also influential in that QMP phenotype. So I think that the really interesting thing is how the aging overlaps not only with the clinical phenotype, but also in the people that study it. The different researchers have different parts of the elephant that they have been interested in. And really, I think a wonderful aspect of today is to get folks together to maybe look at the elephant holistically.
I had one other thing I just wanted to add to this in response to Gil's question. I think actually Patricia's data was really interesting, showing the relationship between the mediation effect of neuronal dropout with TDP-43 being an important mediator of that and less so with tau. And I do think there's something about the phenomenology of TDP relative to other pathologies that's really related to structure. So maybe episodic memory might be affected in those with other pathologies like Lewy body, but when we look at structure, TDP is a really strong modulator of it, and therefore, I think structure is important to look at. And the other thing I'll say also about PART is there is some recent data. I mean, certainly I think PART plays some role in memory loss, but you never see that kind of severe atrophy that we see with TDP-43. And there is some data that just came out. I can't remember who the authors are. That might be, where Brock stage, there's a higher rate of TDP-43 in Brock stage 3-4 PART cases than 1-2, and that if you look at those individual pathologies in relationship to structure and memory, TDP plays an important role in driving memory loss in those cases.
So before we get to Ron, I'm just going to make one comment that neuronal loss data was really very surprising, and I want to give a kudos out to Sonal Agrawal, who's hopefully listening, because she's collecting all this data in our cohort right now. And we were very surprised that the TDP was so much related to that neuronal dropout, and it wasn't tangles, and that continued even when we controlled for hippocampal sclerosis. So it wasn't just being driven by those with hippocampal sclerosis. TDP is doing something specifically to the hippocampus, and there's profound neuronal dropout within the hippocampus. And so the mechanism does seem to be different in with TDP and hippocampal structure in neurons. Ron, you wanted to ask a question.
One, thanks for everybody for commenting this morning on these important issues. And the combination neuropathology is a given. But what we don't know is the temporal evolution of the different pathologic entities. So at age 70, maybe in an individual, amyloid and tau were playing out. When they got to 80, then TDP kicked in, vascular disease, as Claudia was saying, is along the way. So what we really need is a serial rollout of biomarkers. Dave's going to talk a little bit this afternoon about some of the imaging measures. And I'm thinking that both fluid and imaging measures serially over time may inform us on which of these pathologies are kicking in at this particular point in time. At autopsy, we don't know, right?
Right.
So.
No, that's a great point. We have some clues from the pathology and autopsy studies. If you remember the hippocampal volume that I showed you, it was really only in the dementia patients that TDP-43 was really strongly related to the hippocampal volume, whereas it was only Alzheimer's that was contributing to the volume loss of the hippocampus before dementia. So I think that timing thing, there's clues that TDP-43 might be later when it's with Alzheimer's disease, but I think what you're saying is absolutely correct. What is driving the early process is going to be really important to tease out.
And that could have therapeutic implications as well.
Yeah, absolutely.
We have a number of questions online, and we're at time, but I think we'll go maybe like 5 minutes over. We also have about 40 minutes at a later time for discussion. So we'll get to as many as we can now, and then hopefully folks can hold theirs or put them in the Q&A. Dr. Sperling?
Sure, I'll be quick because you partly answered my question about PART, but Dave Walk, you'd be proud of me. I do diagnose late occasionally in clinic, but I've been worried then when I get a tau PET and they have a little bit of tau without much amyloid in the MTL. So I wonder whether that's going to be important. And then most to everyone, what you've talked about, how to actually use the overlapping proteinopathies to tell us about ubiquitous mechanisms related to aging. This will come up in clinical trials, but I think these people maybe who don't have amyloid do have TDP-43 and tau and alpha-synuclein late in life to understand, what mechanism we want to go after to empty all of the age-related protein garbage.
So I'll speak to your first part, although I agree with the second part quite a bit. Yeah, I mean, I think one of the strategies we've used, and I think others have used as well, is to and maybe in some ways informed by the data we were just talking about with regard to neuronal dropout, is to look at the sort of amount of tau pathology there is relative to the amount of atrophy or episodic memory loss there is. And I think there are cases where clearly there's just tremendous amounts of atrophy with very little tau uptake. There obviously are going to be these cases that are, in between, where there is a little bit of tau uptake, they're amyloid negative. Is that meaningful or not? And there's some atrophy, but not a lot. And I think those cases are going to be really difficult for us to know. But again, if you look at PART in general, at least some of it is also driven by TDP-43. And so, I think we'll have to learn over time, what's the best approach in those cases. But I think there'll be certainly cases where probabilistically we'll have much less certainty as to what's the underlying pathologic mechanism.
We have a question from Dr. Thal online.
Hi, can you hear me?
Okay. Yes, we can.
Good. My question is focused mainly on the group of late cases that have also Alzheimer's disease pathology. And in Alzheimer's pathology, we have the subtyping from Melissa Murray. And my question is, are these late NC cases mainly found in the group of the limbic-predominant type of Alzheimer's disease? So do we have a subtype of Alzheimer's disease that is already dedicated for the co-occurrence of late?
So I haven't looked at that specifically, and maybe Pete can talk about it, but the limbic predominant that Melissa Murray talks about is where the tangles are really predominant in the limbic area. So, whether or not they have TDP or don't have TDP, and what limbic predominant versus the other forms of AD look like in comparison to TDP-43, I don't have a good sense, but I do think that group in her study had very shrunken hippocampi, and the theory was that it was because of the tangles themselves in that limbic predominant.
Hi, Dietmar. So just to add to that, I agree with what Julie said, but so just to keep folks aware that Dr. Murray and the Mayo Group came up with a concept that limbic predominant versus a more neocortical predominant form of tangles in Alzheimer's disease, different patterns. One thing, there's no way you can point to a certain case and say this one is limbic predominant, this one isn't. But as a group, the more limbic predominant is the older folks. Mm-hmm. So as you get older, there's more limbic predomination of the balance of the tangles, and that also happens with more limbic predominance of the TDP. And as far as I know, there is no specific cutoff for those two delineation markers. There's no criteria for that. But it does seem to be very credible that we're not designed to get to be 90 years old from nature. And so that if we poop out, we have this MTL structural and biochemical problems that promotes misfoldingopathy that occurs both for tau and TDP, and they bump into each other as well because the same cells frequently contain both of those opathies. So
I would also argue.
Oh, I'm sorry.
Okay, I would also argue that in the older age group, those people have Alzheimer's disease, but they also have PART. So there's two processes going on in the hippocampus as we age. So this limbic predominance in the older age group may or may not be AD tangles. Part of it, not to use PART twice one sentence, might be PART.
Just to add one other thing, which by the way, I don't know if I'm designed to live in my 50s at this point, but or well designed at least. But I think one thing that is worth thinking a little bit about, because there is this interesting phenomenology that early onset Alzheimer's disease doesn't tend to be associated with TDP-43 to the extent late onset is, and those cases do tend to be more cortically predominant, whereas things like alpha-synuclein, we see pretty similar amounts of co-pathology in early onset cases from late onset cases. And so maybe there is something about the medial temporal lobe and aging that makes it particularly vulnerable to these varied pathologies.
One extra interesting phenomenology, though, is that Down syndrome only rarely has late comorbid, interestingly.
One last question online, Dr. Maslia, and we do see the other questions. We'll do our best to get to those later this afternoon.
Oh, great meeting, everybody. And Nina, great meeting. Thank you for giving me the chance to ask the question. And hopefully I will see you guys later at dinner. I was wondering, are all cases with TDP-43 and Alzheimer's disease late, or is there a subset of AD cases with TDP-43 that are not late co-pathology, that is maybe more neocortical predominant TDP-43? I mean, some of these cases that John Trojanowski described years ago that had TDP-43 in other regions, those would not be, that would be considered part of Alzheimer's disease, that TDP-43 pathology, rather than late, or is not possible to distinguish, and all of them have late co-pathology?
Yeah, so I'm going to let Pete talk about this, because this is, I think what you're really addressing is these tweeners, right? Where it's not limbic predominant, and it's more neocortical. And I think we would argue that that's not late.
Right. When in doubt, it's not late. That's my take. Late is a common condition, and there's no need to shoehorn somebody with C9 or granulin or this or that into late. But very, very common, people with advanced AD get late. And it's important for me to put that into my autopsy diagnosis because it contributed to the clinical syndrome statistically if you look at the population. So it's very contributory even when there's severe AD, and so it deserves to be there. But if there's a doubt and there's a bunch of it, way too much of it in the frontal cortex, then it's not late, it's something else.
Right. So I think the point is that TDP-43 is not specific for late, just like tau is not specific for Alzheimer's disease. And if it's an unusual distribution, you should consider other things. CTE has TDP-43 in it. All the FTLDs have TDP-43, and then some of these very rare conditions also have TDP-43. So basically, if it doesn't conform to that pattern, we would argue that it may not be part of TDP-43 and late.
And we certainly see cases that are FTLD in presentation who have AD as the co-pathology with that, either based on amyloid or some degree of tangle pathology. I don't know, Eddie, if you want to speak to that in our brain bank with our co-pathology of AD with but pretty clear FTLD cases.
Yeah, so we see that, and then we also see like older genetic cases, so like C9 carriers that look very late-like, and that's seen. I was talking to Chadi last night. He's seen amnestic C9 or 72 carriers, and Dennis Dixon has seen some of these, and so there are these rare cases. I was talking to Pete. I want to be very careful because our brain banks are very selected. So because I've seen a dozen cases, doesn't translate into that being common in the community. But there is overlap there, including the genetically driven cases, but that's a different, that you don't see those in the community essentially.
Right, which is a great point though, is the pleiotropy that Pete was talking about, where where it is in the brain triggers what the phenotype is going to look like.
Yeah. I think we're going to break now and have lunch, and then we'll come back, and there should be some more discussion time built into the rest of the day. Thanks.
Thank you.
Going good? Okay, so
Okay, let's see. Yeah.
Okay, just press that every time I want to go?
Yep.
Forward, backward.
Backward.
What's this? That's a pointer?
Yep.
Oh, I don't need that really. Okay, go. Thank you. All right, we'll let everyone get assembled, and then I'll start.
Ryan, can you hear us? Test.
Yes, sir. I can hear you.
Okay, thank you.
Mhm.
I don't know. People are still kind of filing in. Want me to wait?
Yep. No,
Start. Okay. Good afternoon, everyone. Why don't we take a seat and get started with our second session? Hope everyone had a good lunch. I am Robert Rissman, and I am just want to mention the fact that I'm moving my research lab from UC San Diego to USC. So you see a lot of affiliations of mine being UCSD and some USC. That is because I'm in a sort of a state of flux at the moment. As soon as the construction is done in my lab at USC, I will move there, and that location is in San Diego, so I'm not physically moving, just FYI. So today, in this session, Henrik and I are going to talk a little bit about fluid biomarkers. I'm going to start off by talking about some of our plasma work. It's in exosomes. This work was just recently published in Alzheimer and Dementia in collaboration with Pete Nelson, Sharice Winston, and Virginia Lee and John Trojanowski at Penn. So let's get started. Hope you can see the slides online. So talking about detection of TDP-43 in exosomes. So we know that TDP-43 occurs in many different diseases, and that neuron to glia and glia to neuronal transfer of TDP-43 occurs through exosomes and other means. And so our real aim was to find more of like a neuronal specific assay for detecting TDP-43. We did some initial work in plasma and it wasn't super successful. So our idea was to actually ask the question, how much TDP-43 is in certain types of exosomes, whether it be neuronal, astrocyte, or microglia, and I'll show you how we did that in a second, and to see whether or not that's related to TDP-43 neuropathic changes. So at UC San Diego, we didn't have very many late cases, as I was telling Julie and Rema and stuff at lunch. But Pete, of course, has a great source at Kentucky. So Pete and Donna Wilcock sent me some plasma samples from their cohort, people who had passed away actually from either late pathology or with not late pathology. So these late NCs here are people who probably had other diseases, right? They could have had Alzheimer's disease. What they did not have is substantial TDP-43 accumulation in their brains. So you can see we had about 60 odd total patients in what we tested, and it's not a greatly diverse cohort, but it's just an initial study here just to see whether or not we could observe any changes between these two. So in terms of the detection of it, we asked Virginia Lee for some antibodies, and sure enough, she had quite a number of them here. We picked one just sort of simply at random, one that was human specific, one that was toward the mid to C terminus as an immunogen. And that is what we used as our capture antibody. Our detector antibody for this bioassay that we made was a commercial source, and it's sort of more of a pan biotinylated TDP-43 antibody. And this one actually we're having difficulty getting now after the pandemic, so it's a bit of an issue. So how do we do this? I mentioned, earlier on in the talk that we separate our exosomes into different cellular types. They are neuronal, astrocyte, and microglia. And we use a magnetic bead capture assay to do that. And we start off with just a commercial kit, the ExoQuick kit. And then we isolate them through FACS sorting, and then we analyze them. We break them open and we analyze them. So I know these exosome methods are sort of somewhat controversial in the field. This is the method that's worked fine for us, and we're always open to trying different things, but this is the most consistent assay that we have actually fleshed out in my lab. So when we actually make the sandwich ELISA, you can see here kind of a rundown. I don't want to take the time too much from you here going through. This is basically a standard ELISA that we made where we coat, block, etc., and we're able to kind of reproduce this bioassay by doing this procedure. And then, of course, like I was saying, we very much characterize and sort our exosomes to make sure we know what we're doing, right? We don't actually just pull them down and say this is a neuronal exosome because we pulled it down with L1-CAM. We'll actually sort it through and make sure we recapture, and that's what we use as our recovered exosomes. And we always use CD81 because that is a exosome marker itself. So we try to keep the number of CD81 exosomes common throughout all of our assays so that we know we're just comparing differences in cargo. So what did we see here? So it actually turned out very different than I thought it would. I thought I would see it in neuronal exosomes, and sure enough, we did not see the difference there. So comparing our in-home ELISA with one I bought, we bought one from China, I think in Wuhan, Coasty Bio. We see very similar trends, but our in-house ELISA seems to be seeing much more than the commercial one. And as you can see here, I don't know how easy this is to see for you guys online, but in neuronal exosomes, you see a good amount of TDP-43 between the non-late and the late participants, like donors. But there's really very little difference, and there's quite a bit of intersubject variability. The difference really came, and again, this is to our surprise, in the astrocyte exosomes. There's a very large amount of TDP-43 protein in astrocyte exosomes from late donors versus people who have other diseases. In fact, these numbers are so low down here in ours that essentially it was zero. Okay, there was really very little in the majority of cases. They did not have any TDP-43 at all. When you look at the microglia, it's still a little bit of a mystery to us, but both the assays showed two different directions, which I thought was very odd. I don't know much about the antibody, the one that's commercially available, but yeah, they're showing completely two different things. So there may be different species of TDP-43 that are in exosomes that are detected with different antibodies. So sort of interesting. So I mentioned this earlier, in thinking about plasma itself, we weren't particularly successful in finding these effects in plasma. You can see here in just overall plasma that we actually removed exosomes from. This is what's left over. We saw no differences between late and non-late donors. And that goes for both assays, both the commercial assay and the one that we made. I think still more work on this needs to be done. Again, this is sort of a preliminary look through plasma. I think, once we get more samples and, really start looking at many of these, we'll see whether or not there's parsing out a difference, because you can see, again, the variability here is a little bit high. So kind of summing up, because I want to leave some room for Henrik's CSF presentation. So we can see TDP-43 very easily in neuronal exosomes, microglial exosomes, as well as astrocyte exosomes. We don't see much in exosome-depleted plasma, but we see a massive difference in the amount of TDP-43 in astrocyte-derived exosomes between late and non-late participants. I mean, it was so obvious, as I showed you. So our future directions are to understand, the generalizability of this, and indeed, Pete has sent us some other samples, and we're looking for collaboration. If any of you all have good collections of late participants, please let me know. We're happy to test them through our platform, see what they look like. And then also understanding really what goes on in just native plasma, right? This is, it's a complicated procedure. If we're going to use this to identify late participants, having to isolate exosomes is a major pain, right? And again, there's a lot of variability in methodology. For things to really be useful, I think, as Claudia said earlier, they have to be reliable. This has to work more than just my lab. So this work is ongoing, and a little outdated here. This manuscript is actually published, like I mentioned, in Alzheimer and Dementia earlier this year. So I'm going to turn it over to Henrik now to talk a little bit about some CSF data he has. Henrik, did you gain control of the screen?
Yes, I think I will gain control now.
Yeah, that's great.
And then I have the slide deck. We'll continue on the
Yes.
next slide that you presented. Thanks a lot, Robert.
Okay.
I think I need to.
What should I do?
I think perhaps Dwayne will
just
help
sit
me
down?
to. Yeah, you can sit down. There we go. Now I can share. Wonderful, wonderful, perfect. Good. Thanks a lot for the presentation, Robert. And thanks for having me also. Sorry I can't be there in person. It's been such an interesting day. I've learned a lot. So just to reiterate what Robert said, when looking at TDP-43 in both plasma and CSF, there is definitely no clear biomarker signal. And this has been studied a lot by Marcus Otto and his team in Ulm and now in Halle in Germany. So the protein is easy to measure in plasma and CSF, but no relationship with TDP-43 positive neurodegenerative diseases. What I will say now will be inspired from work in ALS and FTD and such things. And I fully understand that the candidate biomarkers in CSF might not be of relevance to late TDP-43 pathology, but still I think it's very encouraging that there are some interesting, very new potential small findings that we could continue to work with. If we instead look at pathological forms of TDP-43, phosphorylated TDP-43 has been suggested as such a form, and this is a study from China that was published a few years ago. There are a couple of other studies as well looking at phosphorylated TDP-43 with some differences between ALS patients and healthy controls like this. We should continue to look at, of course, for modified forms of TDP-43, but in this study they also saw differences when measuring just total TDP-43, which has not been replicated by other groups. So this is a difficult topic. Let's see, I will just move this study came a few years ago from Schialo et al. In Italy. And this is a study on lumbar CSF, where a similar approach to RT-QuIC-based assays for prion protein or alpha-synuclein was used. So here you see basically you take a lumbar CSF sample and you spike in recombinant TDP-43, and then you look for seeded misfolding, and you detect this by simple THT fluorescence. It's a very honest paper. You see that the data are a bit noisy. If you compare it with prion RT-QuIC assays, it's much clearer in prion disease and also much clearer in alpha-synuclein. I contacted the team behind this assay just before this meeting and asked for an update, and they state that they are continuing to work on this. It still looks promising, but it is a little bit of a difficult assay and it's noisy. So but we should of course follow this, because it would be nice to be able to see if we could detect misfolded forms of TDP-43 like this. And then we have this. This slide. We have tried to adopt another approach to TDP-43 because we also failed in detecting interesting changes in TDP-43 CSF levels. So instead we have been working with the GENFI cohort in Europe, and this is a frontotemporal dementia initiative, the genetic forms of frontotemporal dementia. And as you know, there are genetic forms of frontotemporal dementia that go with TDP-43 pathology, seen in orphan granulin mutation carriers. And basically what we did was that we took, here you see the sizes of the groups. We performed CSF proteomics using TMT proteomics, and then we looked at the biomarker patterns. And specifically, in this to gain some knowledge on this, we grouped people with likely TDP-43 pathology. So here we have control individuals versus symptomatic TDP-43. And in this comparison, you see that the classical neurodegeneration markers show up here, but then there are a number of other markers that also show up. If we instead do controls versus pre-symptomatic TDP-43 associated forms, very little happen. You see the reduction in granulin in the progranulin mutation carriers, but not much else. Here is another attempt to get to TDP-43 related changes, and that was by comparing symptomatic tau versus symptomatic TDP-43 FTD cases. And then we see a number of markers that are changed here. Of course, this is very preliminary, and we can't say at all that this would be related to TDP-43 specifically, but still interesting. I think I skipped this slide in the interest of time, but here you can see the TDP-43 related proteins that we have seen. And they all show up in the symptomatic phase of the disease. They are all reduced, NRCAM, ANC5D, CADM2, and then that is the, let's see if I can move the bar. OPC-ML here, and then you also see a schizophrenia-associated protein that also changes like this. These proteins are very different. I can't see any pattern in them, but they are all relatively highly expressed in neurons, at least. So what we would love to do, of course, is to do a similar type of proteomic study in patients with late and also in combination with AD pathology and also in comparison with the age and sex-matched controls. And then we could see if any of these changes replicate. Then I would briefly just also like to mention a couple of completely new studies. They've been shown on some conferences that I find extremely interesting. And this is also in CSF, changes downstream of TDP-43 pathology. The idea is that loss of function of TDP-43 would lead to inclusion of cryptic exons into transcripts. And then if they are in frame, this will give you cryptic peptides that do not exist in the absence of TDP-43 pathology. So here's one study that is available at bioRxiv just since a few weeks ago. And then here's another one that replicates one of the key findings in the other paper. And here I will just show you the main results. Basically, the first paper showed 18 cryptic peptides from 13 different proteins in CSF from 15 ALS patients. So again, this is ALS. It's not late, but anyhow promising. And then in this study, an immunoassay specific for a cryptic exon encoded epitope in this protein called HDGFL2 was detected in human CSF, and one could see how it increases here in ALS and pre-symptomatic and symptomatic C9orf mutation carriers. So with this, I would just like to be a little bit positive here to TDP-43 markers, although I know that there is a lot of additional work needed in late, but at least there are now some interesting signals in other diseases related to TDP-43 pathology. Thank you very much.
I think we're going to hold questions until we get to the discussion period later. So I think next up is Konstantinos, who's going to talk about MRI and TDP-43.
All right, thank you very much for the introduction, and also thank you for the invitation. In this presentation, we're going to be talking about MRI markers of late. As we all know, latency is a TDP-43 proteinopathy that is common in older adults, and it is associated with an amnestic dementia syndrome that mimics Alzheimer's dementia. Unfortunately, latency can only be diagnosed at autopsy, and therefore the development of a latency marker is a very important goal. So the question is, can MRI fill this gap? We know from AD research that MRI is sensitive to neurodegeneration, and therefore we're not making a big leap assuming that MRI is sensitive to neurodegeneration due to latency. The main question is, how specific is MRI on late NC? And the reason is because, as I mentioned earlier, latency is associated with amnestic dementia syndrome that mimics Alzheimer's dementia, which means that both latency and Alzheimer's affect similar parts of the brain. And also, we know that that mixed pathologies are very common, and that often latency is present in the same brain with Alzheimer's pathology. So the specificity question is an important one to answer, but I believe based on the following slides and work that we're doing in the lab that we can get pretty good specificity. So the first question that we should ask is how do we go about building MRI markers of latency? And the answer is that because we can only get to the pathology at autopsy, we need to combine MRI with pathology in large cohorts, preferably community-based cohorts. And MRI has a unique ability to work both in vivo and ex vivo, something that you cannot do with PET, for example, as far as I can tell. So we can do MRI in vivo and ex vivo, and I'll present both options in the next couple of slides. So in the first option, we image participants with MRI over time. At some point, the participant comes to autopsy. We assess the neuropathologies present in the brain, and then we connect the last MRI information and the pathology information to build the markers of latency. In this approach, what is important to do is to minimize this antemortem interval, and I have a very simple drawing here to describe why. Assume that we're measuring hippocampal volume on the left axis and some neuropathology severity on the right axis, and the horizontal axis is time, and assume that as neuropathology severity increases, hippocampal volume decreases. If we image with MRI, if the last MRI is collected at this point in time, we measure this much hippocampal volume, and then if death occurs at this point in time, we assess this neuropathological severity, and we should be measuring this much hippocampal volume, but we didn't because we don't have an MRI image at the time of death, so we use this last MRI. Therefore, for this antemortem interval, we're making an error of this much. However, if death occurs much later, we measure a lot of neuropathology. We should be measuring low volumes of hippocampus, but we don't have an MRI image at this point. So for this long antemortem interval, we're introducing a much larger error. And the problem with this is that the larger the error, the more we underestimate what MRI can tell you about the pathology. In the second approach, this is the approach we've been following. We follow people with in vivo MRI longitudinally. And again, at some point, we perform an autopsy. We conduct ex vivo MRI within the first 24 hours from death and also at 30 days after death. And then we combine the information with pathology. This combination of the ex vivo MRI and pathology information allows us to develop markers of latency without any antemortem interval, by zeroing out the antemortem interval. And then the combination of in vivo and ex vivo MRI allows us to do translation and also do the testing of the markers in vivo. So these two approaches, the in vivo MRI plus pathology and the ex vivo MRI plus pathology, have been used in the following slides that I'm going to present today. In the first study shown here, Josephs et al. Used in vivo MRI at 1.5 Tesla to study 84 older adults with a pathological diagnosis of AD and reported atrophy associated with EDP43 in the hippocampus and the medial temporal lobe regions. In a larger study published a little later, the medial temporal lobe atrophy was presented again, and it was demonstrated that it is true at Bragg stage 4 and Bragg stage 5, and it wasn't as significant at Bragg stage 6. In the same paper, it was demonstrated that hippocampal volume decreases for increasing Bragg stage in TDP negative individuals, But in TDP-positive individuals, it stays lower than the volume measured at TDP-negative individuals, and also seems to not depend much at the Bragg stage. It doesn't change much from Bragg stage 4 to 5 to 6. In parallel, back in 2011, we performed this ex vivo MRI study at 3 Tesla in community-based older adults, where we looked at the hippocampal volume and hippocampal atrophy. And we studied associations of the shape and volume of the hippocampus with different neuropathologies. Here, we did not use TDP-43 yet in our models. At this point, we used hippocampal sclerosis. And what we saw was a unique atrophy pattern in the hippocampus associated with hippocampal sclerosis, which involved mainly the anterior portion of the hippocampus, but also other parts along the length of the hippocampus. Another thing that we noticed was that hippocampal sclerosis was associated with more atrophy of the hippocampus compared to Alzheimer's pathology. And if we look at some simple numbers on the left, maybe this is much easier. Oh, there you go. If we look at these numbers here, AD-positive individuals had smaller hippocampal volume on average by this much. Hippocampal sclerosis positive individuals had a bigger reduction in their hippocampal volume. And then interestingly, participants that had both AD and hippocampal sclerosis had a very similar reduction in volume. There wasn't much difference. So that was an interesting observation. Then in this study that Patricia showed a couple of hours ago, we see hippocampal volume as a function of different combinations of pathologies. This is hippocampal volume in people without AD, without latency, without vessel diseases. And then this is what happens to the hippocampal volume in AD-positive individuals. And then in late NC positive individuals, you see a bigger drop in the volume of the hippocampus. And when you see AD positive and TDP positive individuals, it seems like it's a little lower, but it's very comparable to when you had TDP alone. In a very fresh study published 2023, any day now basically, done in ADNI and NAC, we see the same behavior. This is the volume of the hippocampus in AD positive individuals. This is the volume of the hippocampus in TDP positive individuals. And this is what happens if you have both AD and TDP. You see that the volume is very similar to when you had TDP-43 alone. So this seems to be a pattern that is replicated in at least 3 studies and 3 different cohorts. In 2015, we moved away from the hippocampus and the medial temporal lobe, and we looked at the rest of the brain. In this analysis, in this image, I'm showing associations of hippocampal sclerosis. Again, we didn't have TDP-43 in our models back then. Hippocampal sclerosis was shown to be associated with lower volume in these medial temporal lobe regions, in the inferior temporal gyrus, middle temporal gyrus, orbitofrontal areas, middle frontal, superior frontal, and so on. Then in 2019, for the late NC paper, we repeated this analysis in 4 times more participants, again an ex vivo MRI study. In this case, we did include late NC stages in the model, and we did not include hippocampal sclerosis in the model. And what we saw was that latency was associated with atrophy in medial temporal lobe regions, in the inferior temporal, middle temporal, temporal pole, insula, and orbitofrontal regions. Soon after that, there was this study published with in vivo MRI at 1.5 Tesla or 3 Tesla that showed the medial temporal lobe atrophy at different stages of the disease. And one interesting finding of this study was that the most frequently atrophied region with latency was the hippocampus, followed by the amygdala, followed by the temporal pole, entorhinal cortex, inferior temporal, fusiform, insula, and orbitofrontal areas. Not the amygdala, the hippocampus was the first most frequently atrophied region. A few other papers have also demonstrated the medial temporal lobe atrophy associated with latency. And in this study that I'm sure we will hear in the next presentation, they also demonstrated hypometabolism in the temporal lobes, in the temporal lobe and in the frontal lobe regions. Similar results have also been shown in a study of LBD, where they compared mixed LBD to pure LBD, and they showed this medial temporal lobe atrophy that they suggested is due to the latency that was present in mixed LBD. Since TDP-43 is typically starts from the amygdala, we performed this study where we investigated the shape of the amygdala in association with various neuropathologies. And what you see here is the association of TDP-43 with shape, and we see that TDP-43 had a unique shape, unique atrophy on the surface of the amygdala. And the second observation that we made here was that AD pathology had a larger and more extensive effect on the amygdala compared to TDP-43. So if we were to summarize some of the findings of the previous studies, it seemed like TDP-43 has a bigger impact on the hippocampus, but it seems like AD has a bigger impact on the amygdala. In this study that was done in vivo in the RAS MAP and ROS, it was another shape analysis project where again we saw that latency was associated with atrophy in the anterior portion of the hippocampus and the subiculum. Moving to other medial temporal lobe structures, again, it was demonstrated that TDP-43 is associated with anterior portions of the hippocampus, the entorhinal cortex, and Brodmann's area 35, when tangles were associated mostly with the posterior portion of the hippocampus, with atrophy in the posterior portion of the hippocampus. Interestingly, the investigators used the ratio of anterior hippocampus thickness over parahippocampal cortical thickness to attempt a prediction of the presence of TDP-43, and they achieved an AUC of 84%, which is very encouraging. This result was shown in one of the previous presentations. What we see here is that hippocampal volume, the rate of atrophy of hippocampal volume in TDP-positive individuals is faster than in TDP-negative individuals. This is in participants that had a pathologic diagnosis of AD. And it seems like the change in rate of atrophy becomes detectable, becomes significant approximately 10 years before death. However, another longitudinal study from the same group demonstrated that the rate of atrophy in latency is lower, less steep than the rate of atrophy in FTLD. In terms of the timing of hippocampal atrophy, this study here demonstrated that hippocampal atrophy became significant at stage 2, TDP stage 2, and that was relatively independent of tangle stage and amyloid stage. Again, all of the participants here had a pathologic diagnosis of AD. Now, moving away from brain structure, last year we published an ex vivo MRI study on 738 community-based participants using R2 relaxation rate. And we demonstrated that latency was associated with lower R2 relaxation rate in this interesting pattern. The reason why this pattern is interesting is because it closely follows the distribution of the pathology in the brain. And because this pattern involves a lot of white matter, we thought of trying to figure out which connections are implicated here. And for that, we used the IIT Human Brain Atlas, and we saw that the main connections that were involved are temporotemporal connections, temporofrontal connections, and temporal basal ganglia connections. We also looked at when the R2 relaxation rate abnormalities become significant, and we noticed that they become significant at stage 2 in the amygdala, hippocampus, parahippocampal white matter, and temporal pole white matter. This is very interesting because stage 2 was a stage where the hippocampal atrophy also became significant, and also the cognitive decline associated with latency also becomes significant at stage 2. And then at stage 3, a number of other regions became significant. These are temporal lobe white matter, shown here, inferior insular white matter, medial orbitofrontal white matter, and occipitotemporal. The reviewers of our paper also asked us to try to predict the presence of latency using R2, and we did that, and I think it was a good idea. So we used machine learning in order to predict the presence of latency, and we see that we were able to predict latency with an AUC of 0.7. Now, is 0.7 the solution? Obviously no, but what I'm hoping comes up from this presentation is that the different brain characteristics that we measure with the different MRI modalities are like different pieces of the puzzle. And by combining all of the pieces of the puzzle, I believe that we can push specificity much higher than that. So this is just one example. This is what R2 relaxation rate itself can tell us about latency. Last year at ISMRM, we presented this ex vivo diffusion MRI study where we demonstrated that latency is associated with lower diffusion anisotropy in medial temporal lobe white matter. And in this case, we saw that the changes, the abnormalities became significant at stage 3. We also looked at associations of late NC with abnormalities in the integrity of the structural connectome. So what we did here, again, this is an ex vivo MRI study. We picked the 19 regions that in the literature, in the pathology literature, we found TDP43 to appear. And then we looked at all of the connections of these 19 regions with each other. And what we saw was that late NC was associated with lower integrity in the connections shown here with sticks. The same connections are shown here with these spaghetti lines. And you can see that many connections, for example, from the temporal pole, the hippocampus, the entorhinal cortex, inferior temporal gyrus, and so on, have lower structural integrity with late NC. We also performed the graph theory analysis, and we saw that latency is associated with lower global efficiency in this network of 19 regions that typically harbor the pathology. And again, we noticed that the global efficiency became significant at stage 3. So the take-home messages is one, that MRI is sensitive to late NC-related brain changes. We and others have shown that latency is associated with atrophy in medial temporal lobe structures, subcortical structures, frontal lobe structures. We presented results according to which latency seems to have a bigger effect on the hippocampus than AD. Latency had introduced unique shape changes in hippocampus, amygdala, and other medial temporal lobe structures. Was associated with lower R2 in a special pattern that is consistent with the distribution of the pathology. Was associated with compromised temporotemporal connections, frontotemporal connections, temporal basal ganglia connections. Latency was also associated with lower diffusion anisotropy in the medial temporal lobe white matter, and with lower global efficiency in a network of regions that typically harbor the pathology. Another common theme was that most of the brain changes became detectable after TDP-43 pathology had reached the hippocampus. Based on all of the above and some data that I cannot show you today, I believe that MRI has the potential to provide satisfactory specificity for prediction of latency. So what are the next steps? We need to continue using MRI to study latency because there's many other MRI contrasts that complete the rest of the puzzle. We need to develop MRI and pathology databases in different labs, and each one of these needs to be large so that we can develop markers and then test and validate these markers across labs. When we use in vivo MRI data, we need to make sure that we do our best. I know it's not easy, but we need to do our best to keep the ante-mortem intervals low, not only because this is important for developing the markers, but also for testing the markers. We also need to move towards fully automated markers of latency, and we need to work on setting up studies where we systematically assess reliability, test-retest reproducibility, and inter-scanner reproducibility in a way similar to what we do in MarkVCID, for example. One important message in my mind is that clinical trials of latency will be most successful with a latency marker, but I think that we need good markers for all the other pathologies too. So the message that I said earlier, that development of a latency marker is an important goal, I think should be changed to development of markers of all age-related neuropathologies is an important goal, because we need to know what is going on in the brains of people that come to clinical trials. With that, I would like to thank the faculty of the Rush Alzheimer's Disease Center, especially my collaborators that are here, Julie Snyder, Patricia, and others that are listening in, the incredible staff at the Rush Alzheimer's Disease Center, and also my students and postdocs at the Emerit Lab at IIT, and of course, NIH for the funding. Thank you.
That was a fantastic talk. Again, we'll have questions later on. Now I get to introduce Michael Groth, who's coming from University of Gothenburg and the Institute of Biomedicine of Seville. Michael, you can take it away.
Yeah, thank you. I have to say it has been really an amazing meeting so far, and I'm really happy to be here and to contribute to the meeting, and actually also to celebrate my birthday with you today, with you all today.
Happy birthday.
Okay, let's see if this works. Yes. So, okay, I think with regards to FDG-PET, it's fair to say that it all kind of started with this seminal paper by Hugo Botha and David Jones from Mayo, where they described a distinct temporal limbic FDG-PET signature that characterizes amnestic dementia patients with autopsy-confirmed TDP-43 pathology and hippocampal sclerosis. And if I move my cursor, do you see that on the screen? Okay. Better?
Yeah, just talk a little bit louder, please.
Okay. So here in this study, as you can see in this plot here, these autopsy-confirmed TDP-43 hippocampal sclerosis cases had a much more relatively much more pronounced hypometabolism in the medial temporal lobe and also some surrounding limbic frontal areas, whereas compared to the typical AD dementia cases, and less pronounced hypometabolism in these atypical temporoparietal areas. And based on these findings, they proposed to use the inferior medial temporal ratio as an FDG PET biomarker for hippocampal sclerosis in this case. And as you can see here in this plot, this ratio actually almost perfectly separates these two pathologic groups. And on the right, we see two examples of how the whole brain hypometabolic patterns look like. So it's much more dominant in the medial temporal lobe in the hippocampal sclerosis cases, in this hippocampal sclerosis case, compared to the typical temporoparietal pattern here in this AD case. So in a follow-up study, also from the Mayo Clinic, they used a larger and clinically more diverse cohort with antemortem FDG PET available. And here again, they found that TDP-43 positive cases had more pronounced medial temporal lobe hypometabolism and also some more frontal hypometabolism compared to negative cases. However, if we look at the inferior medial temporal ratio as a predictor, it didn't really perform as well as in this previous study for predicting TDP-43 positivity. And so the authors proposed to include information from the frontal cortex, from frontal hypometabolism into the ratio to increase the accuracy. However, if we look at the detection of higher TDP-43 stages that are more likely to actually impact the phenotype, then the inferior medial temporal ratio actually did quite a decent job and worked best for detecting hippocampal sclerosis cases. So in our study, we used independent data from the ethnic autopsy cohort to try to replicate the FDG PET signature specific for late in amnestic dementia. And what's interesting here to start with is that in the comorbid AD plus late cases, these really didn't differ much from the pure, relatively pure AD cases, showing a very similar temporoparietal atypical pattern of hypometabolism. But in contrast, these relatively pure late cases showed a remarkably similar temporal limbic pattern of hypometabolism as was described in this previous study on hippocampal sclerosis cases. And so much more pronounced in the medial temporal lobe. And I don't know if you can appreciate that on the screen, but you can almost see a cut between the entorhinal medial temporal lobe and the inferior temporal gyrus here. And so in a direct contrast between these pure late and pure AD cases, the late cases had much more pronounced medial temporal lobe hypometabolism, also some other limbic structures, and here in insula, whereas the less pronounced hypometabolism in these temporoparietal areas, and interestingly, the area with the highest effect size was in this independent sample here was the inferior temporal gyrus. So accordingly, the inferior medial temporal ratio actually did quite a decent job in separating these pure AD and pure late groups in our study. And this didn't seem to depend on the presence of hippocampal sclerosis here denoted by black points. Also, I have to say, so all of these cases were at least late stage 2 in this study. So as expected from the whole brain voxel-wise patterns, the ratio did not really differentiate between AD and comorbid AD plus late cases. However, there were 2 cases in this group had hippocampal sclerosis, and they had quite high ratios, and also their whole brain voxel-wise patterns look much more similar to this late specific signature. So in the next step, we wanted to see what how this would look like in the clinic if we used this FDG PET signature as a biomarker, suggestive biomarker for late in amnestic dementia patients. So for that, we studied a cohort of almost 250 patients clinically diagnosed with AD dementia in the ATNI study. And we used an automated pattern matching approach that searched for patients with an FDG PET pattern that's more similar to this autopsy-defined derived late typical pattern compared to this characteristic AD temporoparietal pattern. And so these are just representations of the spatial correlations. And this was the case for about 10% of these patients, which we denote late-like because they have a late-like FDG PET pattern. And not surprisingly, a larger portion of the cohort showed a typical AD pattern. And there were also several mixed cases that could not be clearly classified into one of these two extreme categories. And finally, there were also several patients who did not show any correlation with any of these patterns because they had low hypometabolism or atypical features such as this occipital hypometabolism here. And these are certainly also interesting cases, but I won't discuss them any further in the rest of this presentation. So these are just the average hypometabolic patterns of the classified AD dementia patients, well, amnestic dementia patients, I should say. And this basically only tells us that this automated pattern matching approach does a pretty good job, seems to do a pretty good job in detecting our patterns of interest. And now when looking at some of the clinical features of these late-like and AD-like FDG PET defined patient groups, then one of the first striking findings is that the late-like patients were indeed considerably older compared to the AD-like patients. So on average 10 years older actually. And they also had a more amnestic predominant cognitive profile as indicated by this cognitive profile variable, which subtracts a composite memory score from an executive function score. And so negative values would indicate a more memory predominant profile. And they also showed a slower, over follow-up, they also showed a slower disease course, so slower global cognitive decline as indicated by MMSE. When looking at molecular biomarkers here in CSF, we see that they had much lower levels, significantly lower levels of, or less abnormal levels of AD biomarkers, both for amyloid and for tau. And yeah, so, okay. And in terms of genetics, they also had a much lower allele frequency of the ApoE4 allele with a complete lack of homozygous ApoE4 carriers in the late-like group. And by contrast, this group had a higher frequency of the T116B risk allele with the complete lack of homozygous carriers of the protective C allele. So in summary, while only being defined on by a specific FDG PET signature as a group, these patients show clinical and molecular biomarker and genetic characteristics that would be compatible with late. This is just data we are working on right now. So where we try to see if we could use a similar approach at an earlier disease stage, trying to classify amnestic MCI patients. And so here, using a very similar pattern matching approach, we found these 92 patients, MCI patients who had this, where the FDG PET hypometric profile very suggestive of late, and we compared them to AMCI patients who had a really pronounced clear-cut AD-like profile. And so we can really speak of prodromal AD here. And basically, the findings are very similar, if not the same. So they did not differ in memory scores at baseline, but had less executive function impairment compared to the AD-like cases. And over follow-up, they showed, or generally, slower cognitive decline over follow-up. Again, ApoE4, same thing, lower frequency compared to the AD-like cases, though still enriched compared to population levels of about 20 to 25%. Okay, this doesn't, yeah, okay. Biomarkers, same thing, significantly less abnormal in these, in the late-like cases, so suggesting that some kind of other pathology may be contributing to the phenotype, or contributing more to the phenotype compared to the AD-like cases. And now in this cohort, we also had at least some tau PET scans available, which we analyzed using a visual read method. And here, the numbers are quite low, but there were actually almost only 10, and only 1 in 10 of the AD-like patients had a negative reading, whereas the majority of these late-like cases had a negative reading of the tau PET scan. So what about other PET modalities as biomarkers for late? So amyloid PET has been proposed as an indirect, as a negative imaging biomarker for late, considering that an amnestic dementia profile without amyloid has a high likelihood of underlying late pathology. And so if we look at here these FDG PET patterns from patients with a negative amyloid PET scan published already a few years ago, then indeed we can see that these seem to have a more medial temporal predominant distribution, more frontal, also more temporal limbic, if you want to call it like that. However, obviously, an amyloid negative dementia is most likely a mixed bag of pathology. And as a note of caution, let's say, for interpretation, I stumbled across these earlier neuropathology studies, and which was really interesting. So I put it here in yellow, and I actually quote from this study that focused on the neuropathology of patients with a clinical diagnosis of AD, but only minimal amyloid pathology, insufficient for pathologic diagnosis of AD. And here the conclusion was that almost half of the participants with a primary clinical diagnosis of AD and without amyloid had an extensive topographic distribution of neurofibrillary degeneration. And then this other more extensive study from of PART cases from the NAC database, it was similarly found that among cognitively impaired PART cases, I think this part, again, two times PART in the same sentence, but I think this part maybe is probably important, that these are cognitively impaired PART cases, and here approximately 50% of these had a Braak stage of 4 or higher, and fourth even a Braak stage 5-6, which is theoretically could be considered sufficient to cause cognitive symptoms. Now we have heard already earlier that that there's TDP-43 may also be a very, and so late may also be a very important driver of neurodegeneration structure and also cognition in part, and we don't have the TDP-43 pathology in these studies. So we don't know what are the actual drivers of the cognitive impairments. However, we do also see these advanced tau cases, or maybe in imaging studies. So these, admittedly, they are rare because amyloid negative amnestic dementia is relatively rare, but they do exist. And these are just two examples here from the triad cohort. So both are these are older patients, the end of their 80s, and both have a diagnosis of probable AD dementia and completely negative amyloid PET scan here and here, and extensive tau PET signal elevations, not only in the medial temporal lobe, but also in widespread neocortical areas. And then this very recent, more systematic analysis of tau PET scans from amyloid negative cases with a clinical diagnosis of AD. It was found by visual read that about 40% of these cases have a positive tau PET read, and 25% have even medial temporal lobe and neocortical, so more widespread distribution of tau PET signal elevations. So PART is may definitely be an important pathologic correlate of amyloid negative amnestic dementia cases. And I think there's still some more work to do to really understand what's the relative contributions of advanced PART pathology and TD and late. Okay, so anyway, given that these advanced tau cases and amyloid negative dementia exist, the same study from Mayo that described hippocampal sclerosis cases also suggested that tau negative amnestic dementia, tau PET negative amnestic dementia may also reflect to at least to a large degree hippocampal sclerosis cases. And so when looking at the FDG PET patterns, a similar pattern is seen in the case that these tau negative amnestic dementia patients have a more pronounced medial temporal lobe hypermetabolism and less pronounced temporoparietal hypermetabolism, which is so characteristic for typical AD. And accordingly, the inferior to medial temporal ratio also quite decently, is definitely elevated in these tau negative cases, and may also separate between these two groups. A limitation of this approach using tau PET negativity is that we may lose, or we may lose here the opportunity to study the relative contributions of tau and TDP-43 in a comorbid context. And so Dave already in this opening presentation already mentioned this approach, which is based on the mismatch between tau pathology, regional tau pathology, and the neurodegeneration observed in the same region. And using such an approach with FDG PET as a neurodegeneration marker, in this study they found a limbic susceptible group, which is characterized by more pronounced limbic hypermetabolism as would be expected by the tau PET signal in these limbic areas. And so this group is characterized by this by a similar temporal limbic FDG PET pattern as we have seen previously for the autopsy defined, autopsy confirmed late cases. And accordingly, they also show these late biomarkers like the inferior medial temporal ratio, including the information from the frontal cortex, elevated. They have more pronounced memory deficits compared to other cognitively impaired patients. And then this most recent publication, which is on the preprint, which I found on the preprint server yesterday, actually, these limbic susceptible cases or limbic vulnerable cases also had increased TDP-43 pathology. So I think I'm really just quickly want to mention these two last slides because we have already discussed it before. So what are, how can we distinguish, or what are the contributions of other medial temporal lobe or targeting age-related pathologies such as PART and HED. Especially an important question because these are highly comorbid. So I've mentioned it before, all cases in all pure, let's call them pure late NC cases in our study actually also met pathologic criteria for possible PART. So there were no PROC 0 individuals, and by definition, they did not have amyloid, at least not sufficient amyloid pathology to be considered as comorbid AD. And then in our study, five of these 7 cases actually also had HED, and this compares, so it's highly enriched. So it compares to 0% of the pure AD cases, pure in the sense of TDP-43 had HED, and in these comorbid cases it was still 20%. So what we did to try to tease out these different contributions to the FDG pattern that we're observing was to find other PART cases who did not have TDP-43 pathology, so PART without late. And in these cases, we did not see a marked temporal limbic pattern as we have seen for late NC. And in a direct comparison, it's clear that this hypometabolism is largely driven by the PART cases who do have comorbid late pathology. And the same story also was observed for the HED cases. So these are HED cases without AD pathology and without late, and they do have hypometabolism in a somewhat unexpected posterior distribution. But in a direct comparison between HED with late and HED without late, it's clear that these cases that have late also show this strong medial temporal and limbic hypometabolism. So in summary, I think that the numbers are really low here. It's basically only case series, but still they suggest that neither PART, at least not advanced PART, and nor HED by themselves are characterized by such a temporal limbic FDG PET signature as we've seen for late and for hippocampal sclerosis in these independent cohorts. Okay, so I'm a bit over time, so maybe I just let you read the conclusions yourself, and gaps and directions for future research. Several of those points have already been mentioned in previous presentations. That I'd like to thank my colleagues at the EBS, especially our smaller imaging subgroup, and Jesus Silva, who's the postdoc in my group and is doing a lot of these research now, also international collaborators at the University of Gothenburg, and my funding sources. Thank you.
Really great data, and happy birthday again. You're 30?
Yeah, not yet.
So next up, David Jones has the unenviable task of trying to bring together the last 4 hours of synthesizing clinical and imaging data, and gives a really nice schema for how they're managing this at the Mayo Clinic.
Yeah, I feel like I earned an extra 5 minutes or something with with that task, but I will do my best. I'm honored. It's been a great day, and I'm happy to present our data. This is mainly our clinical approach. Most of it's published, some of it is not. But I try to summarize things kind of quickly with like a little mind game puzzle there. But that's just telling you I'm taking a functional anatomic approach to this. Localization is very important in clinical neurology. So I try to summarize that localization quickly with like a symbol like this, that AD is not Alzheimer's disease, that's amnestic dementia. That's not involving the functional neuroanatomy, the heteromodal association cortices. So amnestic dementia, not in the spectrum of a functional anatomic clinical syndrome associated with neurodegeneration in the setting of 3 and 4 autonomous folding. So the shorthand for that is that. So no relevant financial disclosures. FDG PET is off-label. So I'll start off with a seminal case and how that led to a lot of my current clinical approach. In some similar cases, going to tau-negative amnestic dementia, our proposed late clinical syndrome, and then a pathologic evaluation, how that sort of schema might work. So this is what I call a seminal case for me. And this is the figure for the A negative, T negative, N positive example in the NIA framework criteria. And you'll see that clinical history there where it says that it was an Alzheimer's phenotype. Once we had the biomarkers, we suspected maybe hippocampal sclerosis. And then they got that diagnosis at autopsy. That's not quite accurate. And I'll take you through my initial encounter with this patient. I would have liked to have called it hippocampal sclerosis without those biomarkers, but that was heretical, so I did not. You reserve those things. But having the negative biomarkers really helps you do that. So she was an 83-year-old female, and I'll just have some quotes from my note, which is about a decade old. And she had a progressive difficulty with short-term memory, perhaps dating back as 3 years. Just highlighting the important parts there in red. Her syndrome was consistent with mild dementia, likely due to Alzheimer's. She scored 124 on the DRS with scoring less than 1 percentile on the memory subtest. Otherwise had largely normal testing. Outside of tests of memory, she had some difficulty with recall and AVLT. But I thought it was strange the amount of difficulty she had with the Boston naming in this setting in category fluency. Her brain MRI showed really marked hippocampal atrophy. And then the FDG PET scan of her brain revealed what I was describing at that time as a reverse cingulate island sign, and that the posterior cingulate was hypometabolic in isolation with additional mesial temporal hypometabolism, not involving the other areas of the parietal lobe. I've modified that, I don't focus so much on the inverse cingulate island sign anymore, but I'll tell you more about that. So I synthesized all that, and I said, given the patient's prolonged course for a dense amnestic syndrome with significant hippocampal atrophy, but the neocortex, it was fine. It was fine what? Clinically. It was also fine on structural imaging. It was also fine on FDG. So limbic only, neocortex fine. And so I'd say that this dementia is localized to limbic circuitry. And given the absence of amyloid, I could more confidently say I thought it was hippocampal sclerosis. At that time I said, or potentially limbic grains. Since that time I've been looking for this clinical scenario to be limbic grains, haven't found it. And then I said, given the absence of amyloid, I said limbic-predominant Alzheimer's disease seems less likely. To this day though, when I don't have A and T information or T negative information, I still consider limbic Alzheimer's disease on the differential of this clinical scenario. And so this is the routine clinical syndrome with some radiologic support. And then I usually do this in my clinic now, and this is what we teach is this clinical syndrome. And that gives me a high pretest probability of getting another test, like an FDG PET, which is typically how I do it. And then that's some highly supportive testing at that point in time. So this is kind of the criteria to put on this framework that I've been using for over a decade, teaching to fellows and residents and things. But say there's this core syndrome. It must be amnestic predominant neurodegenerative for going on for over 2 years. Some routine features are things like older age at evaluation, mild clinical syndrome with largely preserved neocortical predominant functions, hippocampal atrophy out of proportion to syndrome severity. The neocortex is fine, so that's why, it's just the limbic system. And so loss of salient historical semantic information in the setting of mild syndrome. I don't have time to get into the very specific semantic loss these patients have, but happy to do that at some other time. And then the advanced features are, having a late-like pattern FDG and preservation of the neocortex, absence of other degenerative patterns on the FDG. And then some low likelihood of having tau pathology. And so I'll show you some data that supports the logic involved in this. So one of them is tau negative amnestic dementia in those studies, which you saw some of today. So you haven't seen this paper, which was before the FDG paper. And that seminal patient I showed you, she came to autopsy when we were writing this up, and that's when we learned she had hippocampal sclerosis. We called this tau negative amnestic dementia masquerading as Alzheimer's disease. We didn't think it was. You can see in the top row, that's what Alzheimer's looks like: hippocampal atrophy, positive tau, positive amyloid. But then all these cases have very atrophic hippocampi. Their syndromes are mild, but their tau scans are normal. And then their amyloid may or may not have been abnormal, not an important piece of information. APOS T negative was behaving just like A-neg, T-neg in this setting. So here's that case again. And so the PCC and Precunious didn't differentiate AD. It's not a good differentiating thing here. The key was actually that this area is fine, that area is not. And so I do that visually. I just look at these things and determine whether or not that's the case. And so that's this. So FDG is very abnormal in Alzheimer's and all sorts of things. Here's different forms of Alzheimer's disease, memory variant. Here's the FDG, here's the tau. Just you can map one to the other. So FDG and tau. So here's a memory. These are all cases that I saw, made these figures for this paper that we put together in the Lancet Neurology. But so here's memory predominant, language predominant, visual, spatial, executive, motor, behavioral. And so when I say amnesic dementia, that's not these areas of the brain. It's not these things, is what I'm saying either. And so there's so much information in the FDG PET about that type of thing, especially tau, that there's so much information in FDG, you can actually use AI to just take that information and produce like a fake tau PET scan, and it performs perfectly well. The citation here is cut off for some reason, but it's in the archives now, it's in a review, but so it's showing, tau PET, you can differentiate the AD spectrum from FTD and DLB, all right, that's great. So can an FDG where you impute the tau PET. But the nice thing about just using the FDG is you can also differentiate FTD and DLB with the FDG. So you can differentiate everything. So leave the FDG where it is, don't make the tau PET, let's just use the FDG. And so here's just using the FDG, and Michael Grothe showed you a little bit about similar patterns. This is like pattern matching, on steroids, where all these patients, these are represented patients' FDG PET scan of their brain, and the connections show you how similar they are to other patients. And so these green patients have Alzheimer's, lopapenic variant, posterior cortical atrophy. Here's a big cluster of Lewy body patients, their FDG PET scans. Here's progressive supranuclear palsy. Here's Parkinson's disease, here's semantic dementia, behavioral variant frontotemporal dementia. We expect, late disease to be in this area in between those FTDs and those older amnestic Alzheimer's cases. So I'm just showing you FDG can do this. So really, this should be the symbol. Amnestic dementia is not that stuff. We can do that with an FDG. And so here's another view of that FDG in that seminal case. You can see here, it's like a staining of the hippocampus. There's a nice hippocampus there. It's having all the problems. She had a very mild clinical syndrome. That's a severe degeneration. How can it be so mild? Because it's focused just on the limbic system, not the neocortex. Here's another example. You can just look at this. So we had to do the IMT ratio because it's hard to tell people. I look at that and come to that conclusion, but you can look at that and come to that conclusion. If I want to tell someone else how to do that, do it in a paper. I have to do an IMT ratio. But now we have a better way of, pattern matching to all sorts of dementia. So amnesic dementia, it's not that. So here, amnesic dementia is not this. This is a case of dysexecutive Alzheimer's disease, totally on the opposite end. Very severe clinical syndrome. This person cannot do their ADLs. The person on the other side can do their ADLs. They just have a limbic problem. And look, it's like a mirror image. Look at the limbic system in this case. Perfectly fine. Here, targeted in particular. Very different. So then I add this little symbol, amnesic dementia and limbic predominant problem. So this concept combined there in those two symbols. So that summarizes that. So amnesic dementia not in the spectrum of heteromodal association cortices, all those things associated with 4 tau, and it is in the spectrum of localization to limbic degeneration. That's commonly in the setting of late NC. So then that's when we did the FDG PET in tau negative amnestic dementia. And once again, we showed that amyloid did not matter. You get that same limbic hypometabolism, whether amyloid's there or not, in the cases of tau negative amnestic dementia. Amyloid does not matter. And this was just gone through in detail. But you can see this whole, and the thing about the different phenotypes, there's anterior limbic, posterior limbic. I think there are differences in phenotypes, and those do show up. But, so we had to put that in a ratio, and that works both for tau negative amnestic dementia and path proven hippocampal sclerosis. And that's just to show that's just showing that this framework we're putting together is logical, that works. It should work. I'm not saying you should do this to identify tau negative amnestic dementia or hippocampal sclerosis, but in this clinical framework, that it's doing what it's supposed to be doing. So back to this. I know it's hard. This is the key, is reading these FDG PETs, and you want to be able to read them not just in the presence of limbic problems, but in any cognitive problem. I know it's difficult, but we have put together a tool which does this really well. And we're working on that. But so here you can look at a patient's case and compare it to all their case in a well-characterized database from the ADRC and the MCSA, and then look at all the data that went into that. And in this case, it's someone with progressive supranuclear palsy. They have very different FDG PET scattering patterns than a heteromotor association core disease or the limbic system. And they have a telltale sign there in the midbrain. And you can review that data and then actually look at predictions of the tool. It reads it as high probability progressive supranuclear palsy. Then you can actually look at the neighbors and say, well, what did that case look like? Let's take a look real quick so that I make my medical decisions. You can not just trust the tool, but you can actually look at the data that's going into what are similar cases that have looked like this before. They all get diagnosed with progressive supranuclear palsy, and the tool thinks they should because they all look alike. And they do look different on the FDGs, but for some reason the AI thinks they're similar, and that's why. They have this midbrain pattern, and that's what it's picking up on is important for progressive supranuclear palsy. And that's a 4R tauopathy. So there's 4 seminal papers that included this case, in addition to the NIA criteria. So you can see here just some figures, all the same case in those 3 papers and the criteria. So what is the proposed late clinical syndrome? So I kind of went through how we turned this into more of a formal system, but it still requires a lot of clinical judgment about these things. How do you operationally define them to test to make sure these things work? I don't know, but we have done, actually, Nick Cordovulo-Cavalier has done this, and this is very preliminary work to try to put through a scoring system on this and evaluate how it actually works at predicting path. This is retrospective at this point. But we looked at all the path cases that we had this clinical data on and that rate FDG and tried to score some of these features. So you had to have an amnestic predominant dementia syndrome, although you're not getting into the analysis. And then gave 1 point for the age 75 to 79, 2 for 80 to 84, 3 points for over the age of 85. If you had a mild clinical syndrome, AMCI or dementia, Cochran score, in this case, short test greater than 29. You have hippocampal atrophy out of proportion to the clinical syndrome. Talk about how you define those things. You get a point. And then advanced features, there's that late light pattern. You get a point for the IMT ratio, a point for not having another degenerative pattern. And then low likelihood of tau pathology could be defined in many ways. If amyloid's not there, tau's not there. So anything that's amyloid negative can give you tau negative. You don't get anything that you can do to say there's not significant tau pathology, you get 2 points. And so this is a small cohort. They had to have those clinical variables, amnestic dementia and FDG. But in that cohort, there's not a lot of pathologies to choose from that cause that amnestic dementia syndrome. No AGD or anything like that. It's just AD with late, AD DLB and late, LBD and late, or pure late. And then here's how that score works across those groups with just the core features and FDG. I think it does a really good job. And I'll focus in kind of on the question that we're talking about here, which is just AD, AD late, and pure late. It certainly captures pure late. And then it does relatively low scoring in pure AD and kind of intermediate scoring in AD late. And that's just the core features plus FDG. And if you can enhance this contrast by adding in those other advanced features like some tau negativity. But you can certainly find pure late. You can certainly differentiate it probabilistically from AD, and that's just with that scoring system. I think a clinical approach that's really high quality will be better than the scoring system. And so I think that the fact that we can validate the scoring system is helpful, and the papers on tau negative amnestic dementia and these other things support the logical concepts here that try to define a limbic-predominant dementia syndrome that is very commonly associated with TDP-43 pathology. I think that's something that can and should be done. Oh, that's the support. And so in the end, that's the summary. The symbol got more complex. It's more of this. But I would say even if we had a TDP-43 biomarker, like you're still going to need this framework. And given that cases like this, all these semantic dementia cases, these BVFTD cases, ALS, they're going to be positive on such a marker. So you're still going to want to marry that with a limbic-predominant clinical syndrome. So you can't just sit around waiting for a biomarker. We need a clinical approach. And the biomarker can support that and exist with it, but we can't wait for it. Thank you.
Do you want to come up? So I think we had about a half an hour, actually, so this is a big bulk of time to ask questions. Really, I think about any of the talks that have gone on earlier today. Certainly, some real provocative and I think some pretty cool data that we just saw over the last.
There's some in the chat already, I believe.
Okay.
Yeah, so maybe we can start. Do you want to start with those since most people have been waiting a bit, or?
Yeah, I think that sounds great. Nina, do
you want to call out?
Yeah, I can start reading some. So one is, what is the data regarding symmetry of late? Is it largely a pathologically symmetric or asymmetric disease?
I think we have seen at least some asymmetry in our cases, and certainly hippocampal sclerosis is pretty well known to be asymmetric. The exact numbers in terms of like how much an asymmetry marker sort of adds to TDP-43 likelihood, I think is probably not all that well worked out, but I think it's another feature to think about. And actually, one of the things that a lot of these talks got me thinking about, and implicit in what Dave was just saying, is thinking of like ratios of things that are more predictive of TDP relative to things that are less predictive. So, for example, in Konstantinos' talk, I was pretty intrigued by amygdala being affected more in AD than in late, and vice versa for the hippocampus, and maybe that kind of ratio might be useful, as well as some sort of asymmetry ratio may further enrich individuals.
Konstantinos, anything to add, or Dave Jones? No? Okay.
And I would say that we do see asymmetry, but if you look on average, it is left. But that doesn't mean you don't get ones that are asymmetric the other way. So we've known that in Alzheimer's studies for a long time too, and how much it was driven by this. But I don't know that it's we can incorporate that into a clinical system. But it does help inform the biology that asymmetry is common.
Yeah, we saw that a fair bit actually in that mismatch analysis that we did earlier, where a lot of the temporal vulnerable or limbic vulnerable groups were asymmetric.
But it does often raise a problem in our pathologic CPCs where we think there might be TDP if they only looked at the other hemisphere. So it does kind of of clinical path correlations may sometimes benefit from bilateral sampling?
So we've been doing that bilateral sampling, and we indeed find more hippocampal sclerosis if we look at both sides. We haven't analyzed the TDP-43 data yet to look at how asymmetric that may be. So they may be missing hippocampal sclerosis. I don't know that they're missing, the neuropathologist missing the TDP-43.
Pete, you have data on that.
Yeah, something like half are unilateral HS, but those unilateral HSs are almost always bilateral TDP, which is another indication that the TDP is upstream of the HS and the other stuff. Because when you have unilateral HS, you almost always have bilateral TDP.
And another question from this morning, do we now have the majority of the variants around dementia explained? That is, if you add TDP-43, alpha-synuclein, beta amyloid, p-tau, and cerebrovascular disease to a statistical model, what % of clinical dementia can be predicted? If not, what % do we now have accounted for?
Okay, I'll take that one. In our fairly recent paper on attributable risk of dementia associated with various neuropathologies, we found that we could account for 67% of dementia cases using all pathologic data. So there's still a sizable number that can't be fully explained by pathology, but we are getting the majority of cases that way. When we just look at the % of variance in cognitive decline accounted for by pathologic indices in the whole cohort, for example, we're somewhere around 45%. So you can see there's a big difference once we know that people are cognitively impaired, but I don't think we're fully accounting for dementia yet.
Can I just chime in? Because we've had this conversation a lot over the years, Patricia. So the % that are explained, that are we explaining everything, really means something different depending on the statistics that you're using, right? For attributable risk and cognitive decline, how much variance is perceived, how much variance could we explain of someone's cognitive decline or dementia? If you look at age and you look at dementia, on the other hand, the association between age and dementia, if you use pathway analysis, in the study that I showed by Melinda Powers, does show that age to dementia relationship was gone when we put in all the pathologies. So I think it really depends on how you're asking the question. You know, how often do we get a case in pathology where we can't explain a dementia? You know, is relatively rare. So it's really a question of, you know, how much cognitive decline are we explaining? How much variation in cognitive decline is there? And a lot of variation in that decline related to the pathologies.
Yeah, I agree. You know, when we look at cognitive decline and we put all of the pathologic indices in the model, we do lose the association of age with cognitive decline. We know it's not aging per se that's driving down cognition, it's disease in the brain. But on the epidemiologic level, you know, I think when we look at can we fully account for all the dementia cases, you know, the modeling approaches we've used have suggested that we can get the majority, but not all of them that way. But you know,
But I would
it is
say
a difficult issue.
you shouldn't walk away thinking that 40% of people who are demented have no plaques, tangles, Lewy bodies, infarcts, or whatever. That's not the case. Almost nobody in our cohort who has dementia has a pristine brain. It's just not something you don't see. So it's just a matter of how you play it with the sort of the statistical modeling.
So the pathologists just look at it a little bit differently than quantifying. Yeah, so it's that variability we see in the pathology versus whether or not someone will have dementia, right? It's that relationship between, you can have a lot of pathology and not have dementia. So when you start looking at that relationship, it doesn't mean that if you have dementia, we can't explain it. It means that there's a lot of people walking around with a lot of dementia-related pathology who don't have dementia, partially. That's part of the picture, and maybe statistically, you guys have to explain to me more exactly the rest of the picture, because we've gone round and round about this for a while.
Let's go ahead and move on.
I would say conversely, there's people walking around with dementia who don't have identifiable neuropathologies. That's true, and I'd say the most common situation that occurs is in problems with CSF dynamics, and you don't really see anything at autopsy. And certainly, CSF dynamics can impair the functioning of the brain, and that does have a treatment with ventricular peritoneal shunts. But most people probably don't get treated for that, and that's going to impair their cognition, and it'll be really hard to see that at autopsy.
Yeah, thank you. That's interesting.
Yeah, just to echo on that, because autopsy doesn't pick up functional change, and the functional changes are influenced by things like socioeconomics, area deprivation, pollution, other things that will that are difficult to ascertain morphologically, right? Yeah. So a lot of that missing heritability, proteinopathy, pathology is probably functional.
Yeah, I mean, I do wonder about, we sort of alluded to it earlier, brain aging in general, whether or not there is some component of that doesn't have an identifiable proteinopathy. Maybe it's vascular and we're not, seeing it or measuring it well, but, there's, a fair bit of data that if you look at, for example, dissociate out AD versus brain age related effects, the two combine together to, support whatever degree of cognitive impairment there
So
are.
can I say one more thing?
Yeah.
A couple more things. So in our cohorts, up to that point, is we've looked at a lot of imaging measures that explain more cognitive decline than the pathologic measures do. So we have, concierge can list them out, but a lot of the radiographic measures are explaining more, and we're looking pathologically at things that explain more of the decline. And for instance, we're finding that inflammation explains more of the decline, and we're finding that RTAG explains more of the decline. So there's things that we're either measuring or not measuring well, that other things that are happening to the brain for sure that are impacting whether or not you're expressing the pathology.
Okay, next question.
We
It's
got through
okay,
one
thank you.
question.
Is nuclear clearance of TDP-43 also considered as TDP pathologies in the studies?
I missed
Nuclear clearance of TDP-43.
So normally, if you stain a brain for TDP-43, it lights up like crazy, but it's all in the nucleus. When you stain somebody who has a TDP pathology, it's migrated out of the nucleus into the cytoplasm where it's a inclusion body. The antibodies that are commonly used against TDP-43 are usually miss that phenomenon unless they're non-phosphorylated. So this is sort of but I think the answer is essentially that it is a subtype of TDP proteinopathy, but I would call it something that's usually missed. But most of the usual pathologies capture most of the usual pathologies. Most of the usual methods capture most of the usual pathology.
Dr. Duggar online has a related comment, I believe. Can you unmute?
Yeah, it was just the fact of kind of going off the sampling aspect. And I appreciated Dr. Schneider mentioning about not measuring well. So just so everybody understands, when we're doing pathology, we're sampling 1% of the brain. Roughly. People can chime in if they think it's 2%. So when we think of trying to account for these variances, how well are we sampling? We're calling an election with 1% reporting. Yeah, I just wanted to make sure, we have a diverse audience, which is very exciting. If Dr. Schneider, Dr. Nelson, I know Dr. Lee are there. So if you want to comment more on that.
Yeah, you're right. Yeah. I mean,
it's a pretty strategic.
Yeah.
I think it's a pretty strategic 1%, though, and it's the 1% that's oriented towards the places that the changes are happening. So
Always standing up for the 1%, aren't you?
Yes.
Okay, next
Sorry,
question.
bad joke.
Dr. Rabinovich, you have a few on there. Would you like to ask a question?
One was about asymmetry, which was already addressed, but I think I put this in the chat, but I think, there's a lot of promise, I think, in the fluid and imaging biomarkers, but I don't think any of them are really close to implementable in real world practice. I think, even with FDG, we see so much misreading of especially medial temporal hypometabolism in real world practice. And so I think that as we think about coming up with criteria that are actually useful for practicing clinicians, we're going to have to focus on the clinical criteria. Maybe we can use some AD biomarkers being negative to support the probability of late NC if those become more widely used in clinical practice. But I think, the really highly sophisticated MRI and FDG that we saw are really interesting, but I think they're really going to be difficult to implement even in clinical trials, let alone in practice. So that's my takeaway.
Oh, Gail, I would agree with that. And that's why the criteria that we propose has this, core and routine, which is just part of the normal evaluation. And you can get to a moderate probability at that point. And then getting some sort of tau negativity after that, however you'd like to do that, will get you there. But I think FDG is also a way to do that. It's not required. And I agree, readings in FDG PET is a big problem, but it's a solvable problem. And I think the field should work towards solving it because it can help us evaluate all-cause dementias. I think Gladys has a...
Yeah, I have a question regarding this duration of the disease. And I'm wondering, because in Hispanics, the disease has a longer duration. So I'm wondering if measures of chronic stress has been associated with changes in hippocampal volume, could, particularly early life. I'm wondering if this can help us to enrich the clinical profile.
I'm no expert on the chronic stress literature, but there is, certainly a literature around hippocampal atrophy in the context of like PTSD and other life stressors. I don't know if there's a direct link with TDP, but certainly it puts you into, you would think it would put you into a more vulnerable state if you've had those experiences in your life when you then do start to develop other age-associated cognitive
do we have the diverse cohorts to look at these differences in SDA, social determinants of health or particular chronic stresses?
Yeah, no, I think that we need more diverse cohorts to be able to look at that. I think, we're at beginning stages of adding to the diversity. And I think, one of the major steps within the ADRC program is some more formalized measures of social and structural determinants of health. Our center, like many others, have started to collect that data as well on their own. And I think that needs to be a concerted approach that we all take. And I think kind of speaks a little bit to what we were just talking about before, that all of these conditions occur in the face of, a lived life. And that's going to influence the degree to which any unit of pathology potentially causes a unit of change in cognition. And so these other factors, I think, are super important for us to consider. I might just say one thing to Gil's point. I mean, I agree with him, wholeheartedly that we've really struggled with bringing imaging into practice, particularly more sophisticated imaging. I do hope, and maybe we as a field can advocate more for more kind of quantitative imaging, more automated approaches. Now that we are, I think, again, I'll repeat, entering a more precision medicine era. I think, other fields, I think, would find it ridiculous that we have all these tools in place and no one uses it in clinical practice. We've been doing this for 20 years, and I think it's time to start to, up the field and really advocate for those kinds of changes. It's insane that we don't.
For the rest of the questions, at least until we get through them, I'd like to prioritize the virtual ones just because we'll have a chance tomorrow in the room to discuss more, and the other team members of the subgroups. So one from Dr. Kukel. I'm going to shorten it a little bit. What work has been done to characterize the asymptomatic phase of TDP-43 late?
Questions.
So I can speak a little bit to that, but maybe Patricia can join in. Because you already mentioned that you're looking at decision making and looking at some of these higher cortical functions that may diminish with time in aged persons. And Patricia has a very in-depth study of decision making where we did see a relationship with TDP-43. However, it wasn't specific. So I don't know if you could speak more to that, Patricia.
Yeah, this is a tricky one, of course, because we don't know what the prodromal or preclinical phase of late is. Even AD, it can be hard to figure out. But we are trying to sort of back up our behavioral assessment so that we're capturing higher order behaviors and sort of less traditional cognitive behaviors in ways that might tap into brain regions and things that might be more amenable to TDP. And we have seen that TDP does have, a significant association with these kinds of behaviors. And sometimes in the context of TDP, we don't see an effect of AD, which is typically where we do see our strongest effect. So it may be that, these kinds of changes, functional changes in higher order abilities like decision making, are something that indicate that, something like TDP is coming down the pike. And, I think it's early on, of course, but we, are definitely interested in that. And I know other people here have mentioned, interest in looking at other behavioral manifestations, and we're open to helping think through what are the best ways to do that. But yeah, I think that's one idea.
From a pathological perspective, it does start in the amygdala, and Matt Sykowski did a really nice project looking at the very earliest stages of it. And it's interesting because there are different clusters of patterns in the very beginning, but as you follow that through, all of them seem to coalesce into that sort of stream of going to the hippocampus and then eventually going out through other output points from the temporal lobe. So there does seem to be multiple starting points. Most interestingly, this sort of subpeel around the sort of outside edge of the brain, there are these very subtle pathology that starts, and it's really intriguing that it starts right on the outside of the brain. But then it comes in, and then it goes in a very stereotypic way that's sort of analogous to the Brock neurofibrillary tangle stagings. It spreads through the brain.
And Pete, you're talking about sort of movement of TDP-43 from the nucleus into, let's say, the cytoplasm, when you're saying it's starting in the amygdala.
No, I'm saying moving in the sense of like going from synapse to synapse to synapse.
Okay.
Folks like Virginia Lee have done wonderful work looking at the spread prion-like of TDP pathology through the brain. And it does seem to be that the data are compatible with that. But it's interesting in that it doesn't explode like FTD. And the analogy I make is part stops at Brock stage 4. It stops there. Nobody knows why, but it doesn't have the accelerant of amyloid to get it into the neocortex where it explodes. Similarly, late usually stops at a very modest amount in the frontal, if at all, but it basically really concentrates in the medial temporal lobe, whereas FTD explodes early and destructively in the frontal cortex. There's some accelerant there for the FTD that's not there for late.
So I think it's also important to recognize that when we talk about pathology, we're talking very early on. So Brock 1 and 2, you don't see symptoms yet, right? So we're talking very early on in the course. By the time you see symptoms, it's already typically in the hippocampus. And, I think what's intriguing is what you mentioned, and I think the other people mentioned, speakers, is that inferior orbital, lateral anterior temporal predominance. And what would you think as neurobehavioralists? We think semantic memory for anterior temporal, but there's also inferior orbital that's occurring. And are you seeing things that match with that inferior orbital sort of predilection?
Dave, you want to? Well, there are different. There's a lot of subtleties, I think, as I've looked at cases over the past decade that I think have it. I speak with them a lot and tease apart some different clinical features. And it is different. There are differences. I think there's spreading more anteriorly and posteriorly. But one of the first things, which I think is different from just amnesia, is the type of semantic knowledge loss that's there. I call it, historically salient information that they need to search for. and that's usually missing in a striking way. And the example that's obvious for families is to give details about 9/11. They won't be able to do that. They won't be able to find those memories, access them, and tell you all the details about it. And that's a very unusual feature in the and otherwise be normal and just have a memory problem. And the other unusual features, as it progresses, irritability is almost like universal. Where initially they're very easy to manage and it's a benign problem. The last few years of life, there's a lot of family strife and people talking about they're easy, quick to anger, to snap, and a lot of irritability. That's a pretty common story.
Dave, over here, Ron. I'm just wondering if you guys, say Julie, Eddie, Pete, looking at neuropathology on normal individuals, cognitively unimpaired people who have TDP. Are there behavioral features in those individuals while they're cognitively normal that could give you an insight as to what's the presenting feature, the prodromal feature of the disease? Have you done that? I mean, in normal TDP in normal people?
So we don't have a lot of behavioral data because we don't have study partners. So we don't, for instance, have NPI. We've looked at a little bit of our, behaviors, but it's still, we're still investigating. Decision making for sure seems to be impaired, but some of this other irritability, we don't have as good measures since it's self-report.
I would say I would be interested in what Dr. Jaika has to say about this. We've looked a little bit about it. There are a lot of things that happen early, but then it's not as specific as you might want it to, because a lot of the things that happen early and late also happen early in Alzheimer's, can happen early in Alzheimer's without late. One thing that we found that was surprisingly more specific than we expected, I thought it was going to be RTAG, but it was late, was the thing that was associated with urinary incontinence, a strange thing. So it's sort of popped out and I'd be interested in hearing if anybody else can replicate that. But the answer is it wasn't as specific as I thought we were going to see. For example, the features that you expect to be for an FTD-like thing, which are disinhibition and language disorders, were totally not specific to late.
And I think that just highlights there needs to be better measures to capture these features. I don't think they're out there. Like, I just saw a patient yesterday, 98 years old, clear late limbic pattern. And the most salient clinical feature for her son was the fact that she couldn't give me any details about who the president was during World War II. She was in World War II and she was at FDR's funeral, and she would tell her whole family her whole life, this story. The fact that she couldn't tell me FDR was president during World War II was very striking to the son. Now, may those meaningful episodic memories, be associated with the medial prefrontal cortex and accessing it with the amygdala and bringing those back up so she can spontaneously recall them? I think so, but we don't have measures that capture this.
Next question online, Dr. K, would you like to speak up?
Sure. Can you hear me?
Yes.
Good. So I haven't unfortunately been able to I had to step out, but this may have been asked, but can you comment on what's known about the pathology in the brainstem, the locus, the raphe? These are areas in Alzheimer's disease where there's early pathology. Some people have even posited in the past that's quote where the disease starts. So it may be there are signals or a way of looking at this in terms of the progression in relation to Alzheimer's pathology by looking in the brainstem.
So I'll answer quickly. Thanks, Jeff, for the question. We looked at our first 200 or so cases in Ross Map, and the places we looked in the brainstem, and as Brittany said eloquently, we look at a very, very small sample of the brain. In the cases we looked at, none of the brainstem regions showed significant amount. There was some sparse activity in the brainstem, and Keith Josephs has described that too in the brainstem. But in our experience, tau is much more prevalent in the brainstem, and it's much more. And what I wonder, and I know that we've talked about this before, Pete, is that seems to be a very part-related thing. That as you're developing tangles in your hippocampus as you get older, we see a lot of that pop up also in the brainstem. And even more so, just like with the hippocampus, when you have AD, then it really goes up. So whether or not it's an early AD or is it an early part, I think is still unclear.
It might be an area that could be imaged and add to that kind of potential sensitivity, differential sensitivity of, hippocampal atrophy driven by part or tau predominance or early Alzheimer's versus late.
That's a great point.
Yeah, it's an interesting point. Unfortunately, it's not that controversial. Everybody in this room has some brainstem tangles. It's just a fact.
Okay. Watch that. Are we all asymptomatic?
Well, Michael's not even 30 yet.
Let's not address that
so-
right now. We only have a few
let's
minutes.
not go there.
I have a great question coming up. Given the clear vulnerability of the hippocampus and amygdala and the high density of estrogen receptors in these regions, are there any signs of sex differences in MTL atrophy with TDP-43?
I think Claudia has to answer.
Yeah, Claudia, that one's yours.
Do you want me to repeat it? No.
So I have no idea at all if there are any pathology differences. Oh. Let's see. Oh. So I have no idea at all if there are any pathology differences, which is what really is the question, in the brains of men and women who are given a diagnosis of late. And I do think we should look. From a clinical standpoint, at least so far, we've gotten no signal of a sex difference. Obviously, we couldn't look at estrogen intake in men, but we have roughly equal amounts of men and women who come to autopsy, and at least the pathologist tells us they've got late. I think we really need to get the pathologist to give us a closer look if they have any systematic differences. And maybe even look at these differences in regard to whether or not women took replacement therapy, for example.
Yeah, women get older, but I don't think that they get much more late. 30 seconds.
Well, I mean, men know how to avoid late very well by dying young.
Okay, I think this may be our last question. Professor Thal asks, a clinical definition of late by amyloid and tau negativity overlaps with the SNAP construct. Would you suggest that we should limit the SNAP diagnosis to those amyloid negative cases that do not fall under the late definition, or will late replace SNAP?
I mean, SNAP is a generic term for non-AD, pathophysiology. And so in my mind, particularly in the appropriate clinical context, someone with an amnestic syndrome and a lot of the features we've talked about are going to be enriched in SNAP cases that have late. There are other things that produce SNAP outside of late. But I think it's a pretty significant proportion of those with, again, a kind of amnestic syndrome with temporal limbic, either structural or functional changes.
Yeah, I guess I would just say SNAP. I mean, it seems maybe like it's a little outdated, this term, and it's kind of a catch-all for, what we couldn't explain in the context of having pronounced neurodegeneration. I do think that one thing that has really stood out in these presentations is it does seem like TDP-43 is a primary driver, though, of atrophy in the hippocampus. So even though SNAP is heterogeneous, I mean, it might be a key underlying etiology for SNAP.
Yeah, I'll just add one thing, maybe going back to even Gil's point, is I think simple hippocampal volume itself, and where it's at least on the more severe end, maybe the bottom quartile, as we were talking about earlier, will probably be insensitive because it'll miss cases, but I think might be relatively specific towards TDP-43 related, MTL change. And I think that's one that, again, could be implemented fairly easily.
And we're going to give Dr. Sperling online the last word here.
Ooh, okay, well, actually, I think Dave partly made my point because I agree that SNAP is a catch-all and outdated, but we're about to for clinical practice, people come in not necessarily with dementia, but MCI, amyloid negative. What do we do? How do we algorithmically sort them into late versus part or what? And I think there's an opportunity with the hippocampal volume. And also, Rob, I was thinking about LEARN, because we have these people who did decline without amyloid, and also even in A4 at relatively low levels and decline more than expected, or had greater rates of hippocampal atrophy than you might expect for a given amount of amyloid. And I would algorithmically develop this so that you can use the more commonly used hippocampal volume, as you just said, Dave. And I would actually think about how you do this, because we're going to have plasma. Everyone, I suspect people are going to be using mostly p-tau measures in the clinic soon, and algorithmically figure out, who should then go on to get additional imaging when their p-tau is negative and they're on the suspected non-Alzheimer pathology route.
Yep, I think I agree with 100% everything you said. And I think thinking of easier approaches, at least to start algorithmically, particularly in existing data sets, will be, I think, really useful for us to start to do. I think I'm getting the end of session.
There's a hook.
The hook, yeah, is coming on.
I can feel it.
So I think we have a break until 3:15. So we'll see you back in 15 minutes.
Thanks, everyone.
This shot, it goes to room shot. Room shot. Want to go back to room shot? Yeah, okay. Because we don't want to. It's been flickering. That's why. Okay, all right. So are you? No, that's fine. I'm not. Yeah, right now break. Let me go to the Zoom. Oh, okay. Then you can minimize this. Minimize? Yeah. Okay. So we'll see the 3 or 4. That one or that one. Okay, let me. Yeah, because this one that we're looking at is going straight down. Sure. Share screen. Sound, yep, okay. Meeting controls, yeah, real quick, yeah, we need to move back, yep. Okay, make sure, check it, make sure it's working. We might need to, can you try now? Back. Yeah.
Okay. All right, so we're ready to go for the genetic risk factors subcommittee talks. It'll be me and then Dr. Rodemakers and Dr. Young, and then Dr. Fardo will finish it up. I'm giving sort of the overview of the topic. from an overview perspective, the impact of genetics on dementia is huge. It's very large. From this 2020 science paper, it's up to 80% of the risk for dementia. Here we're talking about AD is genetic, which is very large. But here we're not actually talking about AD as in Alzheimer's disease, plaques and tangles. We're talking about amnestic dementia, because almost all of the genetic data that we've gotten to date on GWASs have been on clinically rather than pathologically characterized individuals. In terms of what we won't talk about today, and it's sort of, I think we're talking about gaps and opportunities. I think these actually represent opportunities. Dr. Farda will talk about more gaps and opportunities, but things we're not going to really talk about is directly, and it was because the people in the subcommittee thought that we're not quite ready for prime time for this yet. But these are opportunities for the future, the use of genetics data in clinical trials to predict responses to intervention and as exclusionary genotypes, the use of polygenic risk profiling in the clinical setting, and talking about how we relate to patients, the genetic data. All these are things we're not going to talk about. Instead, I'm going to talk about 4 things. One is the risk alleles that have been identified to be associated with late, some aspects of the importance of pathology, age, and ancestry, insights into the pathogenetic cascades, and a little bit more about how those can be useful. All right, so the current gene variants that have been linked to late NC phenotypes in published studies sort of come in 2 flavors, one that have been identified through GWAS and one through focused gene testing. The latter, for example, are TMEM and GRN, which were first associated with FTD and FTLD, and ApoE, of course, is associated with Alzheimer's disease. It's important to note, though, that these are not 100% specific genes. TMEM has been associated with leukodystrophy in the past. Granulin is associated also with neuronal ceroid lipofuscinosis. ApoE, it's hard to think of an aging-related thing that ApoE is not adversely associated with. So it's not just that these are only FTD and this is only AD SNPs as well. But I'm going to be talking also about the GWAS associated SNPs, and these ones you can look up separately. So these ones have all been replicated to be associated with late, and we'll talk a little bit more about that. First, though, I'm going to say why it's important to think about the phenotyping pathologically, age, and ethno-racial ancestry. So one of the key things we've talked about a lot today, and this is a figure showing it, is the H&E stains. These are at the same scale what an anterior hippocampus looks like normally. And with HS, it's very shrunken, it's atrophic, and a lot of the cells are dead. It's been replaced by gliotic scar, basically. And it's important to note, as said before, that most of HS is a subset of late NC. And this set of figures is going to show the importance of 2 things. 1, the pathological phenotyping, and 2, the importance of age. So this is a group of about 1,000 individuals in NAC who have been genotyped, and all of them had the clinical diagnosis of probable AD. So they were all thought to have Alzheimer's disease, and the y-axis is the allele frequency of ApoE epsilon 4, and the x-axis is age. So all these people have clinical Alzheimer's disease, but the frequency of ApoE E4 plummets. Interesting. So there's a real important interaction between the genotype and aging. This is the same exact group of people, but the proportion of individuals who have HS pathology. So the very difficult to get away from conclusion is that a lot of these people with low ApoE allele frequencies who are AD dementia actually have HS and late rather than AD per se. In addition to the importance of age and pathological phenotype, there's also issues of ethno-racial and genetic background. So this is something we're interested in currently, and there are very large differences in the alleles according to geographic ethno-racial ancestry. So this is just a fairly pedestrian look at groups of people with African ancestry and European ancestry from the 1000 Genomes Project. There are 5 European groups and 7 African groups that were gotten their genotypes. And what you can see is there's huge disparities. First of all, these are the frequencies of the risk alleles. And what you can see is that the risk alleles for late are very common in multiple populations, but they really differ considerably from population to population. Now, can you say with confidence that a TMEM related therapy is going to quote unquote work in Europeans, but not in African ancestry people? Or on the other hand, maybe granulin, it's the opposite, but there could be a very dramatic difference. Answer is we don't know. The example of ApoE shows that it's very unpredictable how the genetic background will pop out as an impactor, but it has a very strong indication for us that we need to factor in and get more diverse samples, and we have a ton to learn, and we shouldn't take anything for granted. I'm sorry for advancing it like that. So another point about genetics is it provides insights into pathological cascades and the directionality of the changes that happen in the brain. Going back yet again, so the HS, this is a control brain with no TDP pathology. This is late, but no HS. And this is this Schlimpsy atrophic sclerotic hippocampal sclerosis with late. That's the sort of the progression that we've been talking about, and to acknowledge that hippocampal sclerosis was the first pathological manifestation that was recognized, and highlight Dennis Dixon again. And Dr. Fardo back there did the first GWAS of this phenotype, and we highlighted the presence of a gene called ABCC9. Later on a completely separate sample of individuals, we did a regression analysis for the different subtypes of late. And we found that the TDP drivers, TMEM and granulin, are associated with this transformation from no late to late. Also, ApoE is associated with the transformation from no late to late, but ABCC9 is associated with the transformation from late to late plus HS. So it's a little bit similar to that, what I told you before about how nothing to A beta, there are a number of different genes that are associated with that, but BIN1 is more associated from A beta to tau. So there's a different sort of hierarchical sequence of the mechanism. Looking then just at this ABCC9 related gene that's related to HS, it's actually interesting on a number of different levels, including the possibility to accomplish one of the great underachieved goals of genomics, clinical relevance, because ABCC9 is a druggable target. And so this is something that Dr. Jaika is going to talk about later. We have a 5-year NIH-funded placebo-controlled randomized trial of Nicoranda, which is an ABCC9 targeting drug. And we have a recruitment based upon biomarker profile that would enrich for people that have late. So this is a practical, that came about completely because of a genetic screen done by Dr. Fardo, and then Dr. Jaika and his team do a clinical trial based upon that. In addition, it's really important to stress the importance of the neuropathological end of phenotype. So an example of that is sort of poster child is WOX, WWOX. It's a gene that was a GWAS hit for multiple different Alzheimer dementia GWASs. So Alzheimer's dementia GWASs with tens, hundreds of thousands of subjects. But the key thing is that almost all of these subjects were clinically rather than pathologically evaluated. And when we saw this, we were like doing, because Dave's GWAS, this is table 4 from the body of that GWAS, identified WOX as one of the late hitters for HS. So we were like, hey, maybe it's Alzheimer's dementia, but it's hit for late instead. Because ADNC, Alzheimer's disease neuropathological changes, can contribute to the clinical syndrome of AD type dementia. However, so can late. And indeed, when we did a follow-up study of people that have been fully phenotyped for both Alzheimer's and late and other pathologies, WOX hit for late, but not for ADNC. So this is the mythic p-value cutoff. On the locus zoom plot, here's WOX gene, and it goes under there for late, but not for neurofibrillary tangles or A-beta or any other AD-related neuropathologic change. And this is the same data, but in tabular format. Not going to get down in the weeds. This is all published. The point is WOX variants were associated with late, but not with AD, and it underscores the importance both of late as a driver of amnestic dementia and in general of the use of pathological endophenotypes. So here you have gene mutations. Late is a strong driver, as we've seen it over and over and over again today. WOX variants have previously been associated with this phenotype. However, our data indicate that WOX variants are probably associated through late to Alzheimer's dementia. Another really important point is at this point, we're limited by the sample sizes, as Dr. Fardo is going to talk about. Honestly, just the low-hanging fruit have been found, or the genes that have been identified from other diseases. So we got the Alzheimer ApoE, and it hits. We got the FTLD, TMAM and granulin, and they hit. And we have a couple others that have been linked to AD dementia, and they hit. But we haven't gotten a large enough sample size to say, hey, what's really specific for late, and how can we better understand and tease apart this mechanism? I would say that pleiotropy is a big part of this, and that means that one gene can do multiple different things. For example, the tau haplotype drives AD pathology because it makes more tau. It also drives the part pathology because it makes more tau. But AD and part are totally different diseases. They have different natural histories, different epidemiologies, and other aspects of their genetic components that are different. So pleiotropy and having overlap of the genetic risk factors is okay to have things still be different. I want to say very much thank you to Dr. Fardo and Katsumata. I'm not a card-carrying geneticist, but these guys are, and it's wonderful to work with them. ADDC and NAC have been awesome partners, as has Rush, who's been amazingly giving in terms of data and pathology and insights. I also want to highlight, now that I have just one more moment of plenary, whatever, Dr. Silverberg has really been amazing in driving this field forward, and I want to say thank you very much. In addition to that, I want to just sort of put on my cheerleader pom-poms and say that Dr. Silverberg's program, the ADRCs, have had a pivotal role in this whole thing, indicating what is pathology that matters, what are the ones that don't matter, where's the fluff, where's the reality. There's no sort of shortcut to it, but I really appreciate the support from NIA to enable us to get this done. And with that, I'm done. Now we have Dr. Rodemaker's.
Hello, everyone. Can you hear me?
Yes.
Okay, it's hard to hear you,
Yes.
but I'm assuming you can hear me. So hello, everybody. Good afternoon. Good evening to Europe. That's where I am, and I know several people online are as well. It is my pleasure to talk a little bit more about the two of these risk factors that Dr. Nelson already sort of introduced you to, which is progranulin and TMEM106B, which actually have been tested, like he said, as candidate genes because of their link to a different disease, which is FTLD-TDP. So the way we've structured these talks is that you've heard sort of an overview of the risk factors with ABCC9 and WOX as the ones who came out of the GWAS is really for late. So now I'm going to focus on granulin TMEM106B because of the link with FTL-TDP. And then in the next talk, you're going to hear more about ApoE and the link to Alzheimer's disease. So I come from the field of FTLD, which, as you'll know, is a different disease. And we heard very clearly that FTL-TDP is not late. But there is a lot of important things I think that we can learn from FTLD-TDP. And so this is a disease that people tend to refer to as a young onset dementia with an average age of onset around 60. But I do have a lot of cases in our cohorts that are also as young as 30, but also as old as 70s and 80s. So it's definitely not that old people cannot get FTLD-TDP. But of course, they don't get the typical memory problems. They get the behavioral and personality changes. Now, more than 50% of those people have TDP43 pathology as the main protein aggregate that is found. So of course, this is why this is also very relevant to late. And in contrast to late, we see FTLA-TDP really sometimes segregate in autosomal dominant families. And the first genetic factor, the first causal gene that was found for FTLA-TDP was progranulin back in 2006. And all we knew at that time was progranulin is like this important neurotrophic growth factor in the brain. And patients with mutations had heterozygous loss of function mutations, which would basically mean that they would lose 50% of the progranulin protein. What we didn't know then and what we do appreciate now is that actually progranulin is also really important within lysosomes. It's actually being trafficked to lysosomes, being cleaved there into small peptides called granulins. And we now think it's actually the loss of the granulins within the lysosomes that is the most important contributor to the phenotype. So that's for progranulin for the causal mutations. How did we in the field of FTLA-TDP come across TMEM106B? Well, this was because of a genome-wide association study in patients with FTLD with TDP pathology. This was actually really new at the time. In 2010, we did the first GWAS really focused on a pathologically confirmed cohort. What was a little bit controversial at the time was that some of the people in that cohort had progranulin mutations. The gene had just been identified a few years before that. And because all patients with progranulin mutations have FTLD-TDP, they were allowed to be part of the GWAS study, which is, of course, a bit counterintuitive because we're trying to find here risk factors for the disease. But if they already have a progranulin mutation, it would be more sort of like a modifier. But anyway, they were included. And actually, this was probably a very fortunate thing because there was one genome-wide significant hit, which was this locus on chromosome 7 around this gene TMEM106B. And the progranulin mutation carriers really contributed a lot to the signal. And there was some signal in the negative ones, but there was really a strong signal in people with a progranulin mutation. And I'll get back to that in a second. I just want to say that at that time, we knew absolutely nothing about TMEM106B. It was an uncharacterized transmembrane protein, but it was sitting in the lysosomal membrane. And now that we know that progranulin is so important in the lysosomes, this all starts sort of to make sense. So now fast forward 8 years, this link between progranulin and TMEM106B was really validated. We did a very large study with more than 400 unrelated patients. And indeed, TMEM106B is a very strong modifier. And I just wanted to show a family to show that effect. So this is a Italian pedigree with 8 siblings. All the people who have a disease are in black. And then you can see that 5 of the people have developed FTD, but 7 of the people actually had a progranulin mutation. And these 2 individuals here, the one here at the end, they are both over the age of 70, have a progranulin mutation, but didn't develop any symptoms. And if you then put the TMEM106B haplotypes on top of that, you actually see that those 2 individuals carry what we call 2 copies of the protective haplotype. I tend to now turn it around and say that actually everybody who got disease carries at least one TMEM106B risk haplotype. And so I think now we get to the point where we think that you almost have to have at least one risk haplotype in order to get the disease. And it's this exact same haplotype that has now also been associated with latency. Now, TMEM106B, we now know it's expressed with different cells in the brain, neurons, astrocytes, oligodendrocytes, is this lysosomal protein and has many glycosylation sites. And here, all this C-terminal part here is inside the lysosomal lumen. And so, but this is all in progranulin mutation carriers and TMEM106B. But how does this work now in FTLD-TDP without progranulin mutations? Like, is it also there that we see an important effect of these, for example, TMEM106B? So in order to do that, we would turn to our FTLD-TDP GWAS, the latest one, because the one I presented before was from 2010. We now have a new study with more than 1,000 cases. But if we look at all the cases at the same, like if we put all the FTLD-TDP cases in one basket, the ones that don't have mutations, we don't see any association with TMEM106B, but also not with progranulin. That's why I wanted to point out this paper that was also brought up before. Many of the people that are on this paper in the audience, FTLD-TDP is also still a summary of multiple pathologies. I mean, you pathologists know how to really subdivide these patients further. And so there's a type A, B, C, depending on the shape and the type of the inclusions and where exactly they're found. Type A, for example, has a lot of intranuclear inclusions. And it's really FTLE-TDP type A that most closely resembles the TDP-43 type pathology that you also see in late, especially in the late stages of late NC. And so we actually went to our FTLE-TDP GWAS and said, let's just only pick out the people with FTLE-TDP type A. And when you do that, you actually get a significant genome-wide association with variants around the progranulin gene. And this is not causal rare mutations. This is a common variant that's located in the 3' UTR of progranulin. It's called RS5848. And actually, this is an additive model. But if you look at a recessive model, that same variant has a really very, very strong risk for FTLE-TDP type A with an odds ratio of almost 4. And this is a variant that actually changes the expression of progranulin, but not by 50%, like a loss of function mutation, but maybe if we look at brain, is somewhere in between people that have the wild type allele or people with a mutation. So it's maybe like a 20% reduction in progranulin levels in the brain. And we also showed that in plasma and CSF, this variant reduces the expression of progranulin. So partly reducing the expression of progranulin is a risk factor for FTLE-TDP type A. And it's, again, this specific variant is exactly the one that was also associated with late NC in the recent studies. If we look at the gene-based level analysis with MAGMA, so not just common variants one by one, but actually focusing on genes, we actually see 2 hits. Again, the progranulin locus. We see some other genes here, but it's basically all tagging this 3' UTR variant in progranulin. But on top of that, we also see TMEM106B. And so the interesting thing is this is the p-value that you see. I can't see it because something isn't. So it's like 10 to the minus 7 is the p-value in FTLE-TDP type A. But we have no gene-wide association and definitely nothing in type B and type C. So again, this TMEM106B as well as progranulin, these are genetic factors that are only having an increased risk in FTLE-TDP type A, which is the type of TDP-43 that most closely resembles late. And these are not risk factors for FTLE-TDP type B or type C. These are the first time that actually these genes were looked at in late. I think the first time was studies that we did at Mayo Clinic. Of course, we didn't really call it late at the time, and this is something that you've also heard throughout the day. Sometimes we use TDP-43 as a marker or hippocampal sclerosis, and only in the recent GWASs that you just heard about where ABCC9 was found, that's when we really did a GWAS for late. So some of these studies are just looking at how the pathology in Alzheimer's disease cases changes in the presence or absence of TMEM106B haplotypes. And for example, if you have the risk haplotype of TMEM106B, you're more likely to have TDP-43 pathology in AD. Now we would say, well, it increases the risk for late. And so all these studies, I hope I didn't forget anyone, but a lot of work has now been done to implicate these TMEM106B variants and also these granulin variants in late NC. So that's what I wanted to tell you about the genetics. In terms of TMEM106B, I wanted to add one more piece of information that I think is really relevant to this audience. And that is that very recently, very interesting papers came out showing that actually the C terminus of TMEM106B can form amyloid-like fibrils, so in the brain. So basically TMEM106B can also be one of these pathological proteins. And this came from the work on cryo-EM, where just like for tau and alpha-synuclein, they try to look for the different conformations of these amyloid-like species. And when they took FTLE-TDP brains with the hope to basically get the structure of TDP-43, they were very surprised to find the C terminus of TMEM106B as the actual pathology in these brains. And this is not just in FTLE-TDP, this is in a range of different neuropathological disorders. It's very common. It's also increasing with age. And so now there's a lot of discussion in the field whether this is even relevant. But I mean, this audience will not say no to the fact that TDP-43 is relevant, even though it's in a lot of people, especially in people with old age. So we actually believe this is very relevant and important. And we and others made antibodies against this sort of filament-forming fragment of TMEM106B. I just want to show now the work that we just did with Ian McKenzie in late NC, just showing in cases with Alzheimer's disease with or without late. So control here are Alzheimer's disease patients without late, and late NC here means Alzheimer's disease patients with late. Regardless, there's a lot of TMEM106B pathology in all of them. But when we use our antibodies on immunohistochemistry and use a grading system to see how much of the pathology is there, then it's really clear that there is a lot more of these C-terminal fragments in the brain of patients with late NC as compared to those without. We also did another study where we used our antibodies on Western blot and quantified the amount of pathology. So after we fractionate the tissue and go for the real insoluble fraction, we determined the amount of these C-terminal fragments of TMEM mono-6B that we identify. And in this study, we use a range of different diseases, so FTD, but also AD, PSP controls. And we see clearly, again, this increase with age, but also very interestingly, we see a lot more of these C-terminal fragments in people who have the risk haplotype for TMEM106B. And for us, this is a sign that indeed this risk haplotype we know is relevant. So we do believe that this TMEM106B pathology is probably also relevant and really does contribute somehow to the disease that we see in our case in FTLD-TDP, but also in late and in all these other diseases. So those were sort of the things I wanted to share related to FTLD-TDP and what we've learned from them. So in type A, we have two main genetic factors, granulin and TMEM106B, and they are shared with late NC, but not with other FTLD-TDP subtypes. I want to introduce you to these TMEM106B C-terminal fragments that are present across diseases, but really also abundant in late NC, and that the risk haplotypes are associated with this pathology, suggesting that it might be important. So with that, I just have some acknowledgements. I want to acknowledge Cyril Potier, who did all the genetic studies related to FTLD-TDP, but this was a very large study with many, many collaborators, and especially Ian McKenzie and Manuela Neumann for the recent work on the C-terminal fragments. And happy to answer later in the discussion any questions.
I just wanted to point out real quick that Dr. Rademacher was the co-chair of the committee, and it's amazing to work with her.